So good afternoon, everybody, and welcome to the three-day FOGSI ICOG certificate course on infertility. This is being conducted on 3 days, Tuesday the 26th, Wednesday the 27th, and Thursday the 28th of May 2026. Each of the 3 days has a specific theme, and we will introduce that in due course of time. I'd also like to welcome my co-convener, Dr. Sarita Bhalerao, the Vice Chairperson-elect of ICOG, who has worked on the scientific program with me. And we would like to begin by expressing our gratitude to the FOGSI and the ICOG office bearers for giving us this opportunity. Dr. Bhaskar Pal, unfortunately, is traveling and will not be able to attend. He sends his regrets. We have the ICOG chair, Dr. Sheila Mane, here with us. We'll hear from her shortly. Our gratitude also to the other ICOG office bearers, our chairperson elect, Dr. Ashok Kumar, the vice chair, Dr. Sadhna Gupta, and the Secretary General of FOGSI, Dr. Suvarna Khadilkar, is also expected to join us very soon. May we begin with a few simple messages, but before that, let's have the inauguration. Thank you, Nilima. And may we proceed with the formal inauguration, requesting our chairperson, Dr. Sheila Mane, ma'am, to please give us her blessings and introduce the program to us.
Yeah. Good evening to all. And I'm very happy to start our fourth certificate course of this year, that is 2026. And all of you have registered in a big number, which is really pleasing. And Dr. Pratik Tambe and Dr. Sarita Bhalerao, with the cooperation of all of the coordinators, have really coined the program in a very well way. And today we have a female factor infertility and female enhancing surgery. What is pleasing to me is that the faculty is a combination of seniors as well as juniors, and really happy to see that so many juniors are participating. That is the young talent. And I really thank Dr. Sarita and Dr. Pratik for incorporating our young talents into this certification course, because this is a very good platform, I think, where you can address so many people by, virtually. So I don't want to come in between, and I welcome Dr. Seema, who is going to give the overview of the day one topics. And I think some of the seniors who have joined, I welcome Dr. Murlidhar Pai, Dr. Sashmita Dash, and Dr. Renu, as well as all other people, those who have joined early. And I welcome all the delegates. And I can see that the virtually also the hall is filling up. And I can already see that more than nearing 400 people have already joined. And we know that this is the need of the hour. And for a general gynecologist, I think there are so many things to learn from this, as well as I think the budding reproductive medicine specialist. So once again, I thank you all. And I think I wish good luck for all these 3 days, and requesting the delegates, see to it that you dedicate these 3 days for this program, and see that your internet connection is good so that you don't miss the post test. Most of the time you people attend, but something goes wrong and then you are not able to submit. So see to it that your device is in a correct position, and your technicality is being taken care, so that you will be able to get the certificate. And I'm happy to see that so many people are interested, and gaining these points will help you to take FICOG. And we want more and more FOGSI members to take this fellowship. So wishing you all a good luck. Thank you.
Thank you very much, Dr. Sheila Mane, ma'am, for those words of encouragement, and thank you for giving us a free hand in creating the scientific program. I would request my co-convener, Dr. Sarita Bhalerao, ma'am, who is the Vice Chair elect of ICOG, to give us a few words of blessings.
Thank you, Prateek. And at the onset, I must congratulate Dr. Sheila Mane for this all this year's activities. This is the fourth course, and each time I can see the attendance is going more and more. A big thank you to Prateek, who's done all the hard work, I must admit, in making this a fantastic program. I'm sure that you all will enjoy it, and I welcome all of you for this 3 day program. Thank you.
Thank you very much, Dr. Sarita Bhalerao, ma'am. To briefly introduce the program, we've divided it into three sections. Day one is going to be female factor infertility and fertility enhancing surgery. The conveners for today are Dr. Seema Pandey and Dr. Jairani Kamraj. The second day, that is Wednesday, the 27th, is going to address male factor infertility and IUI. The coordinators for that day are Dr. Fasilui and Dr. Monica Singh. And finally, on the third day, that is 28th of May, Thursday, we are going to have IVF, ICSI, and advanced ART. The conveners for those days, that day, are going to be Dr. Ritu Khanna and Dr. Kanti Bansal. To take us through today's proceedings, I would request the conveners for today, Dr. Seema Pandey and Dr. Jairani Kamraj, to please go ahead. Both of them are very well known, eminent clinicians in the field of high risk pregnancy as well as infertility. Seema has previously been an ICOG Governing Council member. She's been co-coordinator for the ICOG Reproductive Medicine course as well. She's an office bearer of ISAR and she's also on the UP ISAR as well. Welcome, Dr. Seema Pandey. And Dr. Jairani Kamraj is somebody who's well known to all of us. She's the past president of FOGSI, vice president of TAPISAR, joint secretary of TNFOG, a lot of accolades to her credit. I will only say this that I could not have found better coordinators for all the 3 days. They are all stalwarts of reproductive medicine, and I'm going to sit back and enjoy the entire scientific program without interfering too much into it. Without further ado, we will hand over to Dr. Seema Pandey and Dr. Jairani to conduct the program. Nilima, is Dr. Suvarna madam there? Has she joined? In
Yet to
case she's
join.
not joined,
Yeah.
then we will have her as and when she comes in.
Yes.
Okay. Seema, please take us through.
Good evening. Thank you, Prateek. A small correction. My CV is old. I'm clinical secretary, sir. So, at the outset, respected Sheila ma'am, Chair ICOG, and Dr. Bhaskar Pal, President FOGSI, and the office bearer and my dear friend Dr. Prateek, thank you for making me a part of this prestigious course. And I welcome you all on day one of this gathering. And today we are having the female factors, which is a very rich amalgamation as I was going through the program, starting from the tubal factor to endometritis to poor ovarian response and hysteroscopic correction. We could not have done it in a better way. Thank you, Prateek and Dr. Sarita, for just curating such a wonderful topics, and all the speakers are going to be really nice. And without any further ado, we would like to kickstart the program, and we would like to invite our first speaker for the first talk, that is evaluation and management of tubal factor infertility by
Can we have the chairpersons introduced?
yeah. So our chairperson for this is Dr. Kalyan Baramade. Should I continue introducing him?
Yeah, please go ahead. As
He
and
is
when he
President
joins in, we will have
IAG
him.
2526, and Dr. Sashmita Dash, Dr. Murlidhar Pai, and Dr. Sashmita Dash is past president Karimnagar of GYN Society, past vice president IMA GDK. I welcome you, ma'am. Dr. Kalyan, congratulations. You are the president IIGs, and Dr. Murlidhar Pai. Welcome, sir. Dr. Murlidhar Pai is professor and vice chancellor, Sikkim Manipal University. I welcome you all for this session, where there are three topics, and first speaker is Dr. Renu Singh Gehlot. I would like you to introduce her and welcome the speaker. Thank you, sir.
Dr. Sashmita, do you want to go ahead?
Good evening, everyone. And the first speaker is Dr. Renu Singh. And I was going through the biodata. She is a renowned gynecologist and the renowned laparoscopic surgeon. And she is supposed to talk on the tubal factor in the infertility. We all know how important is the tubal assessment. Let us go to the topic proper. And I would request Dr. Renu to continue.
Dr. Renu Singh is from Kanpur and she's a very important center head and contributor to our ICOG courses, both the reproductive medicine as well as the gynecological endoscopy.
Dr. Renu, please.
Yeah.
Yeah, please go ahead, ma'am.
Am I audible, sir?
Yes, ma'am, you're audible.
Yeah, so thank you everyone for giving me the invitation. It's really indeed a great task which you guys are doing. I must congratulate Seema ji, Pratik sir, Seema madam, and everyone there for curating such a online platform where all the youngsters can learn. So I'm the opening batsman. That's really a creditable thing for me. So tubal factor infertility. So this is basically an evidence-based decision matrix where we will be analyzing all the things. As far as the Indian landscape and pathology is concerned, we know in India it accounts for 25 to 30% of primary and secondary infertility. And we should not forget the female genital tuberculosis is contributing to 24 to 48.5% of diagnosed tubal cases. Though, yes, we have got non-tuberculous drivers like PID, ascending chlamydia, and post-abortal endometritis and salpingitis when the patient take drugs on their own or get a hit with puerperal sepsis. Now we have to understand the pathophysiology of salpings. This is a very beautiful cut section of the salpings where we can say there is endosalpings, myosalpings, and mesosalpings. So when the patient comes to us for recanalization or for tubal cannulation, and then she asks us, ki, Madam, we just want ki you just do our recanalization. So we have to understand this very picture, and this picture should be there on our table so that we can explain them well. Ki it's not like a simple lumen. This lumen has got so many rugae, it has got cilia, which actually plays a very important role as far as the fertility and the tubal factor is concerned. So we have to understand it's an active organ, the fallopian tube, and it has got a highly specialized microenvironment, and it is not just a passive conduit. It orchestrates gamete nutrition, capacitation, and fluid transport. And chronic subclinical infections, they basically target and destroy the cilia. And that basically, even if the tube is patent, is not going to lead to pregnancy. So this basically needs to be understood and needs to be explained. Now, how we are going to diagnose? We know the most common test when a patient comes to us is HSG. It is a wonderful one, and all patients, I think, when first time they are coming to us, should undergo an hysterosalpingography, and it is as accurate as 65 to 85%. But yes, it contains a notable rate of false positive for proximal occlusion, and I think in such patients we should get it done under short GA. So sometimes even while injecting the dye, this aggressive contrast injection can artificially overcome mild distal femoral phimosis, hiding subclinical pathology. So the method how you are doing a HSG is also very important. Initial 3 ml, 4 ml should be slow, and later 2 ml you can push literally. So sometimes there is lymphovascular intravasation. So high injection pressures, they can push contrast into uterine venous, and they do mask the pelvic pathology. So we can see so many things are being diagnosed, the bilateral hydrosalpinx. We do see such type of subarcuate uterus. We see this submucous fibroma and a patient with patent tubal pathology. But lot of information are gained by this, but we have to understand the delayed film nuance is crucial to differentiate the free pelvic spill, which is spreading beautifully around pelvic loops from localized pockets of loculated contrast. So we have to understand, we have to take at least 2 to 3 films to get the clear picture, one for the uterine cavity, one for the tubal pathology, and one for the patency. So we prefer giving it light in one after the other, minimum 3 shots should be taken. And that's why the digital one is really very good, because it gives you a clear picture and accordingly you can take out the film of it. So true tubal patency diagnostic accuracy is very high, but it carries a notable rate of false positives, we know. And there can be sometimes a transient osteospasm if you are, touching the fundus or if you are pushing it too high. So these are the certain nuances of HSG interpretation. You don't get to know what is basically happening. So these are so many nuances. I think I can take a full lecture on HSG, but that will be too much. So we have to learn to interpret, and nowadays I would say one AI should be used. You just take a picture, post it on ChatGPT or any other AI, and you will get a very good diagnosis, very, very close. So ever in confusion, just post this picture there, and then patient is also very happy. Now, if we talk about the non-invasive screening, that is sonosalpingography, it serves as an outpatient first-line choice, avoiding radiation and systemic iodine allergies. But again, it is differentiated. It is steady, non-pulsatile transvaginal contrast installation. It dramatically minimizes the false positive corneal blockage spas, and dual assessment advantage is also there. But the thing is, we are not able to give picture, and lot many things are missed as far as HICOG is concerned. To us, the first choice is still HSG because it stays with us for long. But definitely the gold standard in nowadays is laparoscopic comb perturbation, which allows the complete anatomical visualization, not only of the pelvis, about the pelvic floor, fembrio-ovarian relationship, which is the most important point, which is often missed in HSG as well as HICOG. And in real-time chromoperturbation, you can see laparoscopically. You can even do, this could be both diagnostic and therapeutic. If you find some adhesions, clear it out. If you find femoral block, just clear it out. So most of the time we have seen so many weird conditions where a lot of adhesions are present due to laparoscopy or due to previous cesarean. And then seamlessly you can shift from a diagnostic evaluation into corrective microsurgical procedures like adhesiolysis, cystectomy, or fembryoplasty. So these are differential diagnostic comparative metrics, and again laparoscopy and chromoperturbation, but this should be done first and later on you can switch over this. So again, for any clinical decision pathway, we have to go ahead with age, ovarian reserve, male, and this thing. We are going to have everything in detail. Now, while this is a good thing, when you prepare, you tend to get a lot of new things. So this is Hull and Rutherford classification of hydrosalpinx. I won't go in detail, but yes, this is a good guide. It is used to guide surgery or whether to go ahead with an IVF decision. So I think this will take a lot of time, but this clearly suggests if it is a grade 3 severe tubal disease where you are having a severe hydrosalpinx, which is diameter more than 30 mm. And if there is complete occlusion or pipe stem, salpingitis ischemica nodosa, or you find a frozen pelvis, tubo-ovarian mass, vascular adhesions, mucosal range is absolutely destroyed, flat and deciliated, it's better to go ahead with salpingectomy when there is a severe hydrosalpinx pre-IVF, even if hydrosalpinx is present. Now, there are certain modifying factors. They are maternal age, more than 35, AMH less, significant male factor, and prior failed tubal surgery and bilateral disease. Then there is salpingoscopy, mucosal grading. So what you do, how do you do a salpingoscopy? Hysteroscopically, we can enter into that. And sometimes we can see the normal rigoid, minor focal loss, moderate or mucosal damage, and flat epithelium, major deciliation, and absolutely obliterative fibrosis. So though it is not practically possible to go into the tube, but yes, from the cornual end, yes, we can see a lot of things, and we can grade. Clinically, I think is more important, but yes, we should keep all these points in mind. Now, as far as the focal tuberculosis specific laparoscopic flags are concerned, if you find a salpingitis ischemica nodosa or a beaded tube, which is grade 3, tobacco pouch fimbrial closure, peritubal caseous nodules, miliary peritoneal deposits, it always better to go ahead with IVF. Take a biopsy of these tubercles and deposits, send it there, counsel your patient after ATT for IVF. Now, this case, as you can see now, directly I'll go ahead with the laparoscopy. So if there are adherent tube and adhesiolysis, so this is a diagnostic dilemma. You know what happens? This patient is having this uterus, and as you can see, she has a previous 2 section, and her all the time tubes used to come positive. But as if crucified, these fallopian tubes were densely adherent to the lateral pelvic wall. And once the adhesiolysis was done, simple scissor, we did the adhesiolysis, injecting vasopressin, and we can see the tubo, and yes, the uterus was also ventroflexed. So this ventroflex uterus was also cleared of the adhesion. Anteriorly, as we can see, the basic principle, this is bladder, this is uterus. With the help of simple scissor, we are going ahead, and then uterus was freed. Finally, this fallopian tube, both the fallopian tube adhesiolysis was done, patency was confirmed, and after that, this patient, she conceived spontaneously and she had children. So this was a very simple adhesiolysis with simple scissor, a 20-minute procedure which restores, and she was running from one center to another because her HST was showing that both tubes are patent. So if even after both fallopian tubes being patent, we see the patient is not getting pregnant, landing up into unexplained infertility, it is always good to put a scope and see. So fimbrial ovarian axis rotation is very important. Go ahead with an anatomical reconstruction of physical relation, and anti-adhesion, I just put saline, nothing else. Just clean it well. Don't do anything, khachar pachar, and just put saline over there. Again, here it is very important in most of the cases of endometriosis, or if the patient has gone through multiple abortions or they have gone through puerperal sepsis, such type of adhesions are seen. Where due to this adhesion, even while doing HSG, what will happen? The HSG fluid, the dye will come and get accumulated here because this fimbrial thing was adherent here. So we have to understand the female genital tuberculosis in Indian surgeon reality. We are often seeing such cases in Uttar Pradesh. I don't know about your places, but always keep this thing in our mind. This is leading to silent mucosal destruction by interstitial inflammation. We have to understand by all these pictures, you can see the miliary tubercles, you can see the adhesions, you can also see the adhesion between the diaphragm and the liver. You can see the caseous tubules. You can very well see here the caseation in and around the tube. Now, one has to be very, very careful when we are operating on such cases, because sometimes these cases, if the bowel is adherent, can even lead to fistulas and perforations because they are actually very, very dense. So such type of caseation, they are there. You can just suck it off, send it for biopsy. This is also important. Gene expert, TB interferon, TB gold, and all these things are put. And when such type of tubes, they are there in form of mild or moderate hydrosalpinx, it's always better to do a minimum intervention, explain to the patient, give video to the patient. This is a case of miliary tuberculosis. You can see the tubercles everywhere. So it requires a premenstrual endometrial biopsy evaluated via PCR TB or TB gold and diagnostic hysteroscopy, give, and it is an absolute contraindication. We have to give ATT and switch over to IVF. So proximal tubal occlusion, which is often the overlooked lesion. Sometimes we think it is patent. So it is critical distinction from spasm, and it should be confirmed by laparoscopy, I would say. We are not doing, of course, the fluoroscopic, hysteroscopic tubal cannulation, the first line intervention, because I feel in 60 to 70% of the patient, tuberculosis is the cause. It's always good to put a scope inside if you see a tubal block. This is what we have started doing. Cannulation, the most important thing is it does not restore mucosal function. A patent but deciliated ischemic segment is functionally sterile and always access for coexisting distal mucosal quality, and sometimes it can even predispose to ectopics. So this has to be clear. But people, they really wanted to do tubal cannulation. This is a very simple procedure. Go hysteroscopically. I used to do it a lot 3 years, 4 years back, but now I have stopped it almost. I always prefer doing hysteroscopy and laparoscopy and explain my patients that this is something which is not needed. This can lead to ectopic, and we just go ahead with the IVF because I have seen 3 ectopics after doing tubal cannulations. So this is how the cannula is put in, guide wire is there. And if you put a laparoscope, no, you will see in 50% of the cases as guide wire punctures here and there. So this is important to understand. Give ATT in such cases. Explain patient all the pros and cons and do what is needed for the patient. So acute pyosalpinx is also due to P sepsis or puerperal sepsis post-abortions, patient taking medicines on her own when she is having a low immunity or even after tuberculosis. So you can see a lot of pus here was drained. This pus was sent for culture but came asterile, so it was a tuberculous thing again. And in such cases, pyosalpinx, they represent active, acute and chronic infection with extensive pelvic abscess, needs to be taken seriously. Show this to the patient, make a video, explain it, do a laparoscopic decompression, and then give a nice isotonic saline peritoneal lavage, send the complete tissue. We don't take a chance, excise the tissue completely, do the salpingectomy, save the ovary, show it to the patient. They often understands well. And then intraoperative swab analysis is important, and give her a heavy systemic triple antibiotic therapies to resolve acute pelvic host toxicity. So this is very important. She don't land up into septicemia. So hydrosalpinx or salpingectomy is again an important procedure. We have to understand when we are supposed to do IVF, why we are supposed to do salpingectomy. This needs to be explained to the patient because the retrograde flow of toxic hydrosalpingine fluid, it alters the FOGSI-10 integrin expression, impairing normal endometrial implantation. So we have to explain to the patient in our own language. And what you are supposed to do a simple salpingectomy. That's it. Again, you can see hydrosalpinx was there on both the sides. The salpingectomy was done on there also with the help of simple shearer. 5 minutes procedure. Salpingectomy is done. Biopsy has been sent. Patient has been explained, and patient can be taken up. Next cycle, if she is not having tuberculosis or something like that, she can be taken up for IVF later on. So simple surgery again. Now, hematosalpinx and endometriosis, they go hand in hand. So what this hematosalpinx is leading to, the hemosiderin, it damages basically the core. So excess of everything is bad. So this blood-filled tubal distension is frequently driven by retrograde derived pelvic endometriosis and ectopic residues. It is basically intratubal iron deposit that drives direct subepithelial mucosal fibrosis and muscular damage, which destroys the mechanical tubal motility. And again, the laparoscopic salpingectomy is the treatment of choice in such cases. Here you can see this was one tube. This was very, peculiar case. So we opened it up like I thought it's an ovarian torsion. But when the whole anatomy was clear, you can see this is a complete fallopian tube. Left fallopian tube was having hematosalpinx, or it was having some discoloration, lot of discoloration. Indeed, it was dilated. It was a large hydrosalpinx, probably that's why it has gone the rotation thing. And then only the tube was removed here. ovary was conserved, patient was explained well, and because her rest tube and ovary was normal, so you can see here. So what we did, we just removed the tube, and below that, because of torsion of tube, this ovary was also torsioned. So we left the ovary like that. Ovary was left like that, only the tube was removed here.
Ma'am, we have 5 minutes over time. Can I
Yes,
request you to wind
I'll
up,
be
please?
over
Thank
with,
you.
yeah. Yes, I'll complete. Now, the distal phimosis dilatation, this is one surgery which I really find very promising because of adhesions. If you see, if you find there is simple, only fimbrial phimosis there, simple, very, just with the help of cold scissors. You can give a cruciate incision. This tube was adherent densely into this anterior pyoperitoneum, and from below when we done it, and this patient also have conceived on her own post-surgery. So sometimes such type of surgeries, they really give a very good result. Rather, I would say only in such surgeries, when only the fimbrial block is the pathology due to certain adhesion or something like that, they give good results. So now there are certain things when you are not supposed to operate. There are certain anatomical factors, and any of the two following, if they are present, please directly proceed to the IVF. It is a grade 3 disease, age is more than 35, AMH less than 1, bilateral pathology, and if she is having associated significant male factor and she has gone through prior tubal surgery. So this is Hull and Rutherford grade 3 bilateral complete occlusion and destroyed mucosal rugae. When not to operate, again I have explained, I won't go in detail. Now this is salpingoscopy staging versus surgical procedure. Again, we have to understand, we can go ahead with this, and if it is a Surrey grade 4 or 5, intrauterine pregnancy chance is less than only 5%. Ectopic chance, though it's nil, IVF is recommended immediately. So one can go ahead and read it in detail. So as far as prognosis and clinical outcomes are concerned, for reconstructive surgery and IVF ET protocol, we have to understand with reconstructive surgery, the pregnancy rate is 20 to 40% live birth rate. With IVF, it is 40 to 60%. Ectopic pregnancy risk is as high as 8 to 10%. It is as low as 1.5 to 2. Multiple gestational is like 1%, but yes, multiple gestation can be less than 1% because nowadays we are transferring only single blast, no issues. Time to conception is immediate with IVF, and subsequent pregnancies you don't know, but they require active clinical cycles. So we have to understand. So thank you, friends. That was all my presentation. So
Thank you very much, Dr. Renu. Fantastic talk on tubal factor, both the medical and the surgical aspects. There are some questions in the chat box. I request you to take them in the chat box itself. We will proceed with the next speaker since we are running late. Dr. Anurag Bhate is busy, held up in a surgery. He will join us as and when he's free. Dr. Narendra Malhotra sir has kindly joined in early, and I request the other chairperson, Dr. Sumesh, to introduce Dr. Narendra Malhotra to us.
So very good evening. I don't think I need all this introduction. You let me share the slides so we can go straight away to the talk.
Good evening, sir. Most
Good evening.
welcome, sir. Narendra
Good evening,
Malhotra, sir.
boss.
Good evening. Good evening.
Good evening, sir. You can start, sir. You are well known to everybody.
It's indeed a pleasure to be here in this great teaching masterclass. And can you see my slides now?
Yes,
Yes,
sir.
sir. You can go full screen, please.
Full screen.
Full screen. It is full screen. So evaluating the ovary in infertile women, that's what I'm going to take you through the ovaries in infertile women. And I bring you greetings from our center at Agra. What we're going to try and do in this talk is understand the ultrasound machine, understand what is ovarian anatomy and physiology, interpret ovarian reserve markers, perform a systemic ultrasound evaluating the ovaries, recognize some of the ovarian pathologies which affect fertility, and of course try to apply all these in assessment in infertility. So we all know that ultrasound is the mainstay in evaluating both male and female because it gives you an anatomical diagnosis, It gives you physiological information if you use color. And when you put it 3D, 4D, you get sculpture like actual images. And when you do power angio, you see very slow flowing vessels also, especially spiral arteries and all. And then we can use ultrasound during the operation, during laparoscopy also, and do a lot of interventional procedures. So what are the technical consideration why ultrasound? You need a high frequency transducer because the depth is low. When the transducer is touching, it has to be high frequency. As we remember in the physics, if it is low frequency, it travels far. If it is high frequency, it travels a little less. So you get a better resolution of that areas. And then of course, the machine should have power Doppler, 3D, 4D, preferably if you have. All of us do transvaginal ultrasound for pelvic assessment, no abdominal scan, or only an abdominal scan to get an orientation or where the it's a virgin or an unmarried girl. So you get better textural and resolution, you get better color flow. You can do sampling by putting a needle. It is very easy to schedule, don't need a full bladder. Where there are abdominal scars, where the patient is very obese and the probe is very tender. Now we can do transperineal when you put the abdominal probe at the perineum. And then we can evaluate all the factors of infertility by TVS, whether it's cervix, uterus, cavity, endometrium, tubal evaluation. We are going to today focus only on ovarian evaluation, follicle monitoring, and some stimulation protocols. And of course, use color Doppler. Where we use color Doppler because we want to know the physiology. And this is available as color, as pulse wave, as angio, as 3D, 4D, as power 3D, 4D, as CVI, all have their specific, definite place in pelvic evaluation. So by this, we will evaluate the normal and the abnormal vasculature, especially when we are looking at the ovarian vasculature, we are looking at the stromal blood flows, we're looking at the follicular blood flow and corpus luteum. And I'm going to talk to you all about these. Of course, benign malignant masses, differentiation, trophoblastic flow in ectopic pregnancies, fibroids, ovarian cysts, torsions, inflammatory masses, all is where the color is required. Now, what color Doppler does? Now, color Doppler is telling you how much blood is flowing through that organ. And that means, see, when your heart pumps blood in systole, blood goes forward to your artery. If your artery is muscular, it will expand and let blood go in diastole. And when the heart goes in diastole, the artery comes back and pushes blood forward. So you have a systolic wave and you have a diastolic wave because of the muscularity of the artery. Now, if the arteries are rigid, the heart will have to pump harder. So you get a peak systole very high. And you don't get a diastole because the artery is not coming back or not letting it. So what we call as a high pulsatility index and a high resistive index blood flow when the arteries are rigid and not allowing blood to. Otherwise, an organ should be perfused both in systole and diastole. What the systolic wave is, the diastolic wave should be 30% in height of the systolic wave. So your resistance approximately should be 0.7. That is how easily. What it is doing is when you put the Doppler beam, the RBCs are going fast. So the ultrasound beam goes and the RBCs reflect back the beam. The faster they go, the faster the beam is reflected and it's reflected as a wave. And this wave has what we call as a systole, a diastole, and an end diastole. And by these, you can calculate the RI, the PI, the post index, the SD ratio. All these three values are very important accordingly to. But briefly, clinically, I've told you, diastolic flow, you should see 30% of the systole. If your systole is this much, diastolic flow should be this much. If by looking at the wave, you can know this organ is perfused well. So color Doppler evaluation of the iliacs, uterine artery, ovarian artery, all that has to be done and has its role. Now then we come to the clinical, after knowing what it is, clinical evaluation. So first the patient comes to you, how to clinically evaluate if the ovary is normal, menstrual history, has a regular ovulatory pattern, age, duration, past ovarian surgeries, chemotherapies, symptoms of PMOS. Yes, it is PMOS, not PCOS now. All of us should remember that. And the BMI. The normal anatomy is ovary is an oval structure. Ovary is an oval structure with some follicles inside, and the follicles will be on the various stages. It will be primary, growing, follicular cells, mature follicles, ruptured follicles, corpus luteum. All of this will be seen in an ovary by ultrasound. And this is guided by the brain, hypothalamic, pituitary, ovarian axis. And the ovarian hormones guide the endometrial and the peripheral axis. So you get a complete picture if you know this figure, how the GnRH comes in pulsatile in response to the cortical stimulation and stimulates the anterior pituitary to give FSH-LH, which acts on the ovary, produces follicles, ovary produces estrogen, progesterone, which act on the endometrium, and which acts on the peripheral body, like peripheral body temperature and all. So how do we evaluate all this? We evaluate all this by ultrasound. There is no other modality to evaluate the ovarian function, anatomy, physiology, pathology by anything. And it is possible now. Where do we look for the ovaries? We look for the ovaries first for the size and site, the ovarian reserve, the follicle growth, correlate it with the menstrual cycle and the endometrium. Push and pull sign will tell you whether there is adhesions, ovarian pathologies like cysts, dermoids, endometriomas, tumors, PMOS can be all diagnosed. So that is how the push and pull sign, you can see me doing pushing and pushing in the vagina and the uterus sliding over the peritoneum. So that tells you that there is no pelvic endometriosis. And if you see at the ovary in this other picture, you see that the ovary and uterus are moving together and not sliding over each other. So if they're not sliding over each other, that means the ovary is in the pouch of Douglas and has got adherent to the uterus. So endometrial or peritoneal factor is there. So you find the ovary anterior to the iliac vessels, and then that is the ovarian fossa, and you recognize by its size, shape, and what it has. So ovarian accessibility assessment has to be done the first time, because if the patient is going to go for IVF, whether the ovary is accessible by transvaginal or not, in the dummy cycle, on registration, during stimulation, very high vaginal ovaries may not be vaginally or approachable. So you do abdominal, and sometimes we even do abdominal pickup or oocyte retrieval, and sometimes you might even need laparoscopy. Then we come to the markers of ovarian reserve. Now, the markers of ovarian reserve are biochemical and ultrasound. Ultrasound is antral follicle count, which marks the ultrasound reserve. The problem is with the operator. So operator has to get used to it. So it's operator dependent. AMH is one of the best markers, but the assay varies from various labs. So that is the issue. FSH is also used as a marker, but it's a late marker and it has a cycle variability. So we cannot predict by. Inhibin is an adjunct marker and has got limited routine use. So for routine use, AMH and AFC are done. Now we remember that when the women are young and when the women are old, the AMH will decline sharply. So at 25, the AMH may be something around 4. At 45, the AMH will be less than 0.5 or 0.05. So the AMH declines, and the decline starts at 30 and then it rapidly declines by menopause. So that tells us that the ovarian reserve is finishing. Similarly, the follicle number will also decline. So there is a decline in antral follicle count with age. 25, you can count 20 follicles when you count both the ovaries, and at 45, maybe only 1 or 2. So that decline is to be known. Now, how do we evaluate the ovaries? We look at the, as I told you, look at the iliac vessels, and then you go and scan it longitudinally, go your transverse probe, turn it, rotate it, so you get a cross section. Here it is, and you count all the follicles which you're seeing. Here you can see multiple follicles, big stroma, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. One is the bigger one. So it is a PCO-like morphology, but there is one follicle which is growing. Only if there are small ones, 2 to 10, have to be counted as the antral follicle count. Now, how do we do it? On follicle monitoring is always started on day 2. At day 2, we are going to rule out a persistent corpus luteum cyst, a previous follicular cyst, PMOS, chocolate cyst, proper endometrial shedding, and do an antral follicle count. So basal ultrasound scan will evaluate the ovary for all its pathology. And if the pathology is there, then it has to be treated first before the infertility. So supposing there's a big dermoid, supposing there's a big endometrioma, supposing there is a big hydrosalpinx, all that will need laparoscopy first, and then you will need to go ahead and treat the infertility part. So how do we assess the ovarian reserve? To decide the follicles. How many follicles are there in the antral follicles? What is the stromal blood flow? What is the stromal area? And what is the total volume? Now, the diminished ovarian reserve will be pointed out by low AMH and low FSH, advanced reproductive age, poor response to stimulation previous, and this may require some changes in the IVF protocols, or may require rejuvenative therapies, or may require pooling of oocytes, and that counseling is very, very essential for this woman. Here you see this woman is around 45 and she has only one, two, or maybe the third one. So only 3 on one side, 2 on the other side. So the AFC is 5. Now, when these follicles grow, you measure them either like this, or if the same person is doing, one single diameter can be measured if it is circular, and the same person should be doing it. When it is appearing near ovulation, you see that the lining are doubled. So this is because the blood supply is developed here and the granulosa and the theca cells have separated now. And then you will start seeing a bulge in one area, which is known as the cumulus, just before ovulation. And then the inner lining will enfold. And inner lining enfold tells you that this is impending ovulation. The cumulus can be seen almost in all by cross section and all. And when you see the cumulus, here is in 3D, here is in the 3D in gray. And when you turn the blood flow, you see that the blood flow is also going towards the cumulus. So this will tell you that the egg inside is M2 and fertilizable. Now, if there are too many follicles, then we use what we call as the Sono EVC, or the automatic volume counter, where the machine will automatically measure all the follicles and give it in different colors, in different volumes. And you get a printed report, something like that. It's not the size, it is the volume of the follicle. There are no guidelines to give HCG according to the volume. What about PMOS? PMOS, the name has changed, but the criteria is the same. So antral follicle count more than 20, ovarian volume more than 10, stroma hyperechoic, and increased blood flow in the stroma, which could be high resistance or low resistance, both. Now in this, it will be seen something like this. Ovarian volume can be measured by the vocal of this thing. Then we come to the blood flow to the ovary. The blood flow to the ovary, the ovarian artery enters to the hilum and then divides into small ones, and these are all coiled spiral which go to each follicle. As the follicle grows, the spiral part of the ovarian branch straightens and lets more blood flow. More blood goes, the more gonadotrophins are reaching there and the follicle is going to grow. So you will see that the diastolic, here it is 30%. Here it is almost a little bit more of 40%. So your resistant index is falling to 0.6 or 0.5. So Doppler assessment of the stromal blood flow is very important inside. And with PMOS, there's going to be a lot of it. So here is POMS. You see each follicle has its own spiral artery blood flow. And the stroma also has a lot of. Now, if the stromal blood flow, if you do a Doppler here, has more diastolic blood flow, more gonadotrophins will reach, and this will cause hyperstimulation. So we can predict which ovary will stimulate, which will be resistant PMOS, which will be hyperstimulation. So here we're doing in live by color Doppler, and here the same case by color angio. Color angio will pick up the small vessels. So you see there is a lot of stromal blood flow and a lot of blood flow to the follicles, and this one is likely to get stimulated more. Now then, when the follicle grows, the follicular blood flow circles it. So you have grade 1, you have 2, and you have 3. So just before ovulation, the blood flow should be 3 or 75% of the follicle. This will tell us that this follicle is poor in M2, this follicle is very good in M2. And this one has no blood, so probably it will be an empty follicle syndrome. And when we do a pulsatility peak systolic velocity and the pulsatility index and resistive of the follicular blood flow, we see if the velocity is more than 10, you get the better collection, you get better embryo, and you get better implantation. Then HCG, when you give the HCG. So you give the HCG mean in a downregulated CC-HMG cycle at 17. 18 in a CC letrozole cycle, and if it is a normal cycle, maybe 18 to 20, anything like that. The follicle will collapse, that will tell you ovulation has occurred. It will fill up again with internal echoes, that will tell you corpus luteum blood is there, and there'll be free fluid in the pouch of Douglas. And then when we do the color Doppler of the corpus luteum, we'll see there is a lot of diastolic blood flow. So here the diastolic blood flow is almost 60%. So the resistant index is 0.4. So it tells you this corpus luteum is functioning well. And later on, the whole corpus luteal will get vascularized. And if pregnancy occurs, this will continue. If pregnancy does not occur, this blood flow will go away and the progesterone levels will fall. Now, this corpus luteum is very notorious and it can mimic any diseases also. So it can mimic cyst, it can mimic ectopic, it can mimic paraovarian or follicular cyst. And if it does not rupture and luteinizes, that means the size does not reduce, internal echoes come into it and the blood flow can be. So here is a luteinized unruptured follicle. Very simple. Internal echoes have come. There is hardly any blood flow all around. And so this will tell you that there is a corpus luteum insufficiency because the diastolic blood flow will not go to 60% of the systole. It will remain around 50%. Now, PCOS is POMS now. POMS name has been changed because it is not a cyst of the ovary, which is a misnomer. It is polyendocrine metabolic ovarian syndrome, and we all should be speaking on POMS now. The name change has occurred because there are no cysts, and the focus is on metabolic. The diagnostic.
You say your time is up.
Yeah, diagnostic criteria is the same. These are the last few slides and the rest. So, for management of ovarian pathologies in infertility, we have to diagnose POI, we have to diagnose ovarian failure, we have to diagnose POMS, we have to diagnose anovulatory 1 and 2, endometriomas, dermoids, ovarian tumors, genetic and autoimmune, to come to this thing of what is the problem with the ovary. So the take-home message is comprehensive ovarian assessment improves fertility outcome. AMH and FSH should be done complementary. TVS is the cornerstone of investigation. If you have Doppler, please do it on all cases. If you have 3D, also do it on all cases. And for assessing infertility, history, hormones, TVS, AMH, AFSH, and then manage. That is what should be done for. Thank you very much for giving me this opportunities. All this is available in our step-by-step books and you can read them. And I bring you greetings from FOGSI and of course from our center, which is authorized for training at Agra. Thank you very much, Dr. Pratik.
Thank you very much, Dr. Narendra Malhotra, sir, for accommodating us and coming in early to stand in for the previous speaker. Really appreciate your going out of the way for us. Can we have closing remarks from the chairpersons, please? Dr. Sumesh and Dr. Sashmita. Dr. Sashmita, please unmute. I've sent you a request.
Hello. Hi, Pratik.
Hello. Am I audible?
Yes, ma'am, you're audible.
Yeah. I congratulate Professor
Hello.
Malhotra for
Excellent
this
session,
wonderful talk, and always it's a pleasure to listen to you, sir. And you have highlighted step by step how to assess and how important your ultrasound finding and as well as your interpretation and collaborating with your clinical practice to take a decision in infertility practice. Thank you, sir.
Thank you, Dr. Narendra, for being here and very excellent talk as usual, I think, and very nicely explained. Thank you very much for accepting our invitation for being there in this certificate course. Thank you.
Thank you, everyone.
Thank you. We will have closing remarks from the chairpersons and then we will proceed with the next session. Since Dr. Anurag Bhate is not yet here, we'll proceed with the next session. Dr. Sumesh, any closing remarks?
And
No,
count
it was
is
excellent.
9:31.
So I would like to thank the chairpersons of the previous session for their services rendered. Thank you very much, Dr. Sasmita, Dr. Sumesh Chaudhary for being here. Thank you to the speakers of the first session, Dr. Renu Singh Gehlot and Dr. Narendra Malhotra. We are off to a fantastic start. I request Dr. Seema Pandey to introduce the chairpersons for the next session, Dr. Vatsala Kamath, Dr. Rakhi Goyal, and Dr. Shailenika.
Dr. Jaya is doing, and Dr. Jaya, please.
Yeah. Thank you, Pratik. Special thanks to Sheila Madam for the dynamic work you are doing for the ICOG. Special thanks to our president and to Pratik and all the conveners, my co-convener Seema and all my friends here. Thank you so much for making me a part of this wonderful ICOG master classes, which is very informative, and I can see the knowledge which has been there, fast spreading. More than 1,000 delegates have registered. Hats off to Sarita Madam and Pratik Sir for your wonderful scientific contents. And we are moving to the next second session. I have the great pleasure and honor to welcome and introduce Dr. Vachila Kamath. Madam is the professor in the unit of the Chief of Department of OBGYN from Mangalore, and she is the consultant OBGYN and laparoscopic surgeon and past president of AMC and the State Medical Council of IMA. We welcome you, Madam. Can I have the next slide of Dr. Rakhi Goyal? Yeah, Dr. Rakhi Goyal, she's the senior consultant and center of head for Birla Fertility and IVF Center in Chandigarh. And she has been an executive member for many societies. And she has been an invited national and the various national and international conferences. We welcome you, Madam. Can I have Madam, Dr. Archana Maheshwari, who is the director of the Balaji Hospital from Ujjain. And she's the
Archana is
director
unable to join us because of family issues.
director of Magada Life ART Center, Ujjain. And she's the secretary of the Ujjain OBGYN Society. We welcome you, Madam. So we welcome Dr. Shaili Nigam. She's from the Lucknow. She's the director and the consultant of the Himani Hospital, Janpur, ex-assistant professor of the UNS State Medical College, Janpur. And she has been a member of FOGSI, ICOG, AUGN. We welcome you, Madam. Over to the chairpersons to introduce the speaker of the second session, Dr. Bharati Dure Patil. Over to you, chairperson.
Good evening, everybody. Can you hear me?
Yes, madam. Yes, madam.
So I have great pleasure in introducing Professor Dr. Bharati Dore Patil. She is Director of IVF, Chief Consultant and HOD of Shri Hospital and IVF Fertility, Pune. She was Vice President FOGSI 2016, and she has held various positions in ICOG, FOGSI, and IMA. Over to you, Dr. Bharati.
Thank you so much. Good afternoon, all. And
it's a pleasure to see Dr. Bharati Dore Patil again after a long time. And
thank you.
Vice President of FOGSI.
Welcome, Bharati.
I have worked with her.
Thank you,
when
everybody.
I was endocrinology chair. She was my VP in charge as well for a short while. I remember all this.
Thank you so much, Dr. Pratik, Dr. Sheila Mane. Excellent initiative, certificate course. And thank you for the invitation. Dr. Jayarani, who is very, very close friend, Dr. Seema, all. Thank you so much. I'm feeling very excited. So I'm just sharing my presentation. Is it visible?
Not yet, ma'am.
Now?
It's the browser window you have shared. You'll need to share the PowerPoint window.
Did that. See? Is it?
If you can minimize the browser.
Like this?
No, we are still seeing the browser. Yeah. If you can go full screen, please.
See now? It's okay?
Yeah. Please go full screen. Perfect.
It's okay? Yeah.
Yes.
Okay. So today's my talk is on a basic hormonal profile in female infertility. And this was a very thought-provoking topics, I could say, Pratik, you have been crafted for ICOG certificate course specially. So we will understand endocrine regulation of fertility. What is the interplay between the hormones and especially the proteins, which is something new for you all. We were all focusing on the hormones. I will tell you how they interplay with each other, how we'll review our basic hormonal evaluations, and how we interpret in the common abnormalities in the day-to-day practice, and correlate this hormonal profile in infertility management. So hormonal evaluation helps us to assess the ovarian function, and you all know that this is called ovarian dysfunction, which is a FIGO guidelines, tells us which patients you need to focus for the fertility treatment. Ovarian reserve, as Dr. Narendra is very elaborately explained about it, endocrine disorders and IVF prognosis, especially prediction. So let's know what is the interplay between the ovarian hormones and proteins. Hormones are like directors and conductors of the reproduction. What we usually see, we provide hormones or we assess hormones while the proteins which are inside the ovary are actors or the workers, and that execute the biological function, and that we don't so many times understand, and I'll tell you with the examples later on. So the hormones provides the instruction and timing, whereas the proteins perform the actual cellular function which are required for human reproduction. So example in ovulation, if you see, the director is FSH, which says grow the follicle. The actor proteins then say increase, they do actually, not they say, but they do increase the granulosa cell proliferations, make aromatase enzyme synthesize, and the estrogen, which supports the oocyte maturation. And then LH comes in the picture, and the LH says it is the time for ovulation. So this is a hormone which is just telling this is the time for ovulation, and the proteins which are actually the actors executes the follicular rupture and cumulus expansion, inflammatory cascade, and the luteinization over a period of time. So hormones binds to the receptor will activate the genes, and the gene will produce the protein, and the protein will create the physiological effects. So hormone signal is first, receptor activation is second, the third is gene expression, then the protein synthesis, the cellular function, and then the reproductive outcome. And I'll tell you how this is clinically important when you actually go into the patient's management. So major ovarian hormones, which we see, the steroid hormones, estrogen, progesterone, and androgen. And the peptide hormones are inhibin A, B, activin, and anti-Mullerian hormone, which we know. So these are the hormones which we have to keep in the mind whenever to do the basic hormonal profile of any patient. We have to understand which hormones we are going to see or advise them to do the prescription and then interpret it. And important ovarian proteins are growth factors IGF, EGF, TGF, oocyte-derived protein, that is GDF, that is growth differentiation factor 9, and BMP15. So we used to all know these, so many things are there, but how do you actually practically implement these proteins which are acting inside? What do? They do granulosa cell proliferation. Many times you see the follicle is growing, which goes to 13.5, 14.5, and then it stops. That means the granulosa cells are stopped proliferating. Now that follicle, although growing, the dominance has not occurred because it is not crossed 16 millimeter. So what is playing a role? This will be very easy for you to counsel the patient. Something is been playing inside. And how do you make those actors to do faster or perfect physiological function? It's completely in your ovulation induction protocol. The cumulus expansion oocyte competency, many a times we see in IVF, many do ovulation stimulation protocol and they get a very few number of M2 oocytes. So very few. Where is the thing wrong? The wrong is inside. You have been not understanding the defect inside, and that leads into poor ovarian response, infertility, and maybe premature ovarian insufficiency. So hormone protein interplay during folliculogenesis is this primordial follicle into primary follicle, which you know that AMH inhibits excessive recruitment, and that's how BMP and GDF controls the growth. And now the growing follicle, FSH will stimulate the granulosa cells, and which amplifies IGF of that FSH action. So whenever you are giving the patient, suppose PCO patients are there, and you are giving simple FSH and still nothing has been happening, probably growth hormone is very important in those patients. Dominant follicle selection happens, then the estradiol rises, inhibin suppresses, and the only follicle which has higher sensitivity will survive. And then the ovulation occurs. When the LH activates, EGF-like proteins will start acting inside, proteolytic enzymes, enzyme mediators, and that lead to follicular rupture. So this all is very important for your counseling. Now the patients are not like before, ये नहीं होता, नहीं हो रहा है, doesn't matter, ऐसे होता है. It's not. Many a times you need to tell them that this is all is happening inside. And the luteal phase, progesterone dominates, and VG VEGF protein increase the vascularity of the corpus luteum, which you see. So how do you clinically implement now? So whenever this all information, knowledge you have, how do you clinically implement in these patients? Take example of PCO patient, poor ovarian reserve patient, and in the IVF, what happens? In PCO patient, what happens? There is an interplay disturbance is there because of the excess androgen, hyperinsulinemia that will alter your insulin-like growth factor signaling, which increase AMH and abnormal activin and inhibin balance. Now, in this, we have now completed our 150 patient study in PCO patients, especially resistant PCO patient. When you add a growth hormone to them, how do they actually give a better quality oocytes? Now, why? What was the reason for that? Because you started playing internally. We realized that arrested follicles and anovulation will have to turn into a better outcome. In the poor ovarian reserve or aging patients, reduced AMH will reduce GDF9 and BMP15, and that's how you know that their mitochondrial protein will dysfunction. And that's how they get a low number of oocytes or not bad, good quality of oocyte, and you add your growth hormone or you DHEA, all these when you add, actually you are making internal environment better. So IVF implications, markers used clinically, AMH, inhibin, VEGF, and follicular fluid proteins will make actually now emerging research into proteomics of follicular fluid, exosomal proteins, and ovarian aging biomarkers, which is now soon going to come. So simplified conceptual flow is pituitary hormones, FSH, granulosa theca cells, then steroid hormones comes because of them, E2 progesterone and androgens. That comes on the local ovarian proteins, which is AMH, activin, inhibin, IGF, BMP15, and GDF9. Even if you remember these 4-5, that's fine. This will give you to follicular growth, ovulation, and the luteinization. So these are the basic hormones which you have to do and which one has to understand: the FSH, LH, estradiol, AMH, prolactin, thyroid function, androgen, and progesterone. Not all patients you are going to make this profile for every now and then, but whenever it is required, these hormones are actually basic hormones which has to be seen in the patients. Timing is very important. Whenever you are prescribing hormonal profile to a patient, timing is extremely important. When you do FSH, LH, and E2, you have to know the basics. What are the basal levels? That is day 2 or day 3. AMH you can do anytime. Progesterone, if you want to know the ovulation, day 21 would be the right choice. Prolactin, you can do at any day, but morning and a fasting is better. TSH, you can do absolutely anytime. You need not have fasting, nothing. This is a paradigm shift now in the thyroid stimulating hormone interpretation or timings. So interpret the result considering the age of the patient, BMI, cycle history, duration of infertility, type of infertility, and the medications what she has been taking. Even you see the values vary by lab assays. So the labs which have been, you are sending the blood is very, very important. Simple AMH, when we did an initial research study with Richard Fleming, that time, I think nobody knew also the AMH, and we used to send samples from here for that study. Over a period of time, AMH became a standard of practice here in India and all across. But over a period of time, I started feeling that AMH varies. And I started writing to Richard Fleming, what has been happening to this AMH, which was a robust marker. And the new study has been come that if you take a blood sample and if this blood sample remains on the table for a long time and then it goes to the interpretation, probably your samples, your values will come up and down. So remember, these all things are very important when you do basic hormonal profile. So correct interpretation of the values are very important for prediction. I'm telling you, prediction. The things have been come from management to prediction. Now predict every patient, then management, and then coming to the outcome. So this is a beautiful study, 2020 in 13. It's been in reproductive biology, endocrinology, predictive value of hormonal parameters for live birth in women with unexplained infertility and male infertility. Excellent 70 patients prospective study. Please read. It is open for everybody. Age, what it says in conclusion, age in combination with the presence of ovulatory cycle and a serum TSH and serum AMH is predictive for long-term live birth. So advantage of serum AMH compared with serum TSH is very little variation throughout the menstrual cycle, which makes it very useful tool in infertility diagnosis and prognosis, predictive value. That is wonderful study. Now, second one is the WHO guidelines, which is 2026, is a recent guideline which has come. You see, this was actually WHO Director General has been saying, Tedros, the infertility is one of the most overlooked public health challenges of our time and the major equity issue globally. What do they say? That we encourage more countries to adopt these guidelines, giving more people the possibility to access affordable, respectful, and science-based care. So this is very important when you actually do a patient's infertility profile altogether, and especially hormonal profile, because see, over a period of time we have been actually driven by the hormones, which jargon of hormones to be done, like package is being given, PCO package or any package is given of the hormones, and you just don't know how to interpret and apply to the patient. Please follow these guidelines. This is excellent, extremely good. It is open. It is in Fertility Sterility 2026. Please go through. This is excellent guidelines. Twist time. So real case scenario. Now 2-3 slides and then we'll finish. Patient A comes to you. Now your hormones, you have done the basic hormones. FSH, this is a PCO patient. All 4 patients are PCO patient. FSH is 2.5, E2 is 55, your LH is 7, your AMH is 4. Her antral follicle count is 15 to 20. Which medication will be the best for her ovulation induction? So how do you differentiate the PCO patient? Differentiate the PCO patient in the hyperestrogenic and hypoestrogenic. And depending on that, you start either letrose or gonadotropin or clomiphene citrate. So if a E2 is 55, she is a kind of a about 35, about 25. So he is a hyperestrogenic patient. She has enough estrogen and her FSH level is low. So this patient will be best ovulation induction protocol with letrozole, first line of treatment. If a patient has little higher FSH, low E2 and LH is high and AMH is between 3.5, this patient will be best for the gonadotropins. Clomiphene citrate combination, you can give gonadotropins. Like third patient, if the patient is 2.5 FSH, E2 is 45, LH is 2, AMH is 10, and our antral follicle count is 25 to 30. Now this patient is again hyperestrogenic. Letrose will be best. But along with that, if you give a gonadotropin to this patient, because her FSH is 2.5, this will do a better. And the fourth patient, 4.1, E2 is 75, LH is 7, AMH is 7.5, antral follicle count is 18 to 20. Gonadotropin will be the best for this patient. Try and understand this. I'm not saying immediately you'll understand this, but when you start thinking the hormones and what will be your protocol, that becomes a very easy. How? We can individualize the patient between CC, letrozole, or gonadotropin depending on an E2 level, whether it is hypoestrogenic or it is a hypoestrogenic. And depending on that, your protocol will be best for the patient. Suppose, second example, in low ovarian reserve, which patients will have a better embryos, a pregnancy outcome. How do you evaluate? The patient has AMH less than 0.9, FSH is 4, LH is 1.5, the age is 30 years and the married life is 4 years. On the contrary, the second patient comes, same AMH 0.9, but her FSH is 15, her LH is 8, her age is 32 years, and she's married just 1.5 years, just 1.5 years. Now, which patient will be better according to you? you have to start evaluating that patient. The first patient will be the better patient because even though her AMH is low, her age is better, her FSH is still okay, her LH is still okay. She is not getting exhaustive by quality of her eggs. Even though the number is low, but the quality would be better. The same here, the patient is 32 years, married only 1.5 years, but her FSH is 15 and her LH is 8. That means this is exhausted ovary. This ovary is failing ovary. You probably will not get the better quality oocyte. So you can just predict and tell the patient. When you're counseling to the patient, it becomes easier for the patient. So emerging frontiers now, the new areas, ovarian proteomics, exosomal signaling, ovarian aging clock is very, very important now. Ovarian aging clock, that early ovarian aging is very important to catch in the beginning, that at 32 or 35, less than 35 years. Stem cell derived ovarian proteins, which is now coming up, and AI-driven follicular fluid biomarker analysis, endocrine regulation, paracrine, autocrine, ovarian proteins estimation now is coming. Oocyte granulosa crosstalk is being estimated, and clinical translation relevance is been coming up. So thought ahead is hormones alone are not enough. We have to think about the proteins, what have been playing inside. Protein mediator inside plays a very important role. Oocyte granulosa cells dialogue is must, especially when you do IVF and your follicles or your oocytes are not coming very great quality. You must think about this. Clinical implications in PCO, POR, IVF is very, very important, especially when you do the hormone. Hormone analysis is a reproductive endocrinology. You have to start thinking like a detective, what is been happening. To my, I think my student may be here, but I was just telling her, if the 14 millimeter follicle is not growing, think what is been happening inside, like a detective. Start thinking granulosa cells are not proliferating. Then the apoptosis has been happening. So why this has been happening? Either your FSH, that your director is not been very prompt to make that actor to act like this. That means the threshold is not very good. You have been suboptimal threshold, so increase the threshold, or you have to add LH into this patient. So this is all has to be thought as a clinical implication. Same for the POR, poor ovarian response, and IVF, especially if you're not getting a good quality M2 oocytes. So future is proteomics, and the personalized fertility treatment is very, very important. So modern reproductive medicine is moving from hormonal assessment towards understanding the ovarian proteomic ecosystem, what is giving you the pregnancy outcome. Thank you so much for listening, and I'm open for questions.
Thank you very much, Dr. Bharti Dore Patil, for a fantastic presentation with practical examples. I will request the chairpersons to give their closing remarks, and Dr. Madhuri Patil has requested to be able to speak next. She is in Bangalore traffic and her laptop battery is about to die.
Thank you, Dr. Bharti, for such a lucid, elegant talk with so many practical points. Really, it was a pleasure listening to you. And there was and so many new insights, emerging research, novel biomarkers, and as you said, the ovarian, the inside of the ovary, what's happening there. It was a wonderful. Actually, we went into the ovary. We were actually imagining all those things. Thank you. It was absolutely fantastic.
Thank you. Thank you so much. Thank you.
Okay.
Can I request Dr. Rakhi Goyal to do the honors and introduce Dr. Madhuri Patil?
So thank you so much, and I'll close now.
Hi,
I think you
Dr.
can answer the
Madhuri
reply
and
in
Sonia
chat
ma'am.
box. Huh?
I'll do so. I'll do so.
Good evening, everyone. It's an honor to introduce Dr. Madhuri Patil. She has a long list of honors to her credit. She is currently the clinical director of Dr. Patil's Fertility and Endoscopy Clinic, Bangalore. And without wasting any further time,
I think it's okay. I'll just share my slides. So.
Yeah, I would like you to start with your talk. Thank you so much.
Dr. Madhuri Patil and I have been in charge of the ICOG reproductive medicine course since many years. Thank you for giving your time and sharing your knowledge with all our students.
without wasting time, I would like to start on my topic, which is classifying poor responders by the Poseidon group. So all of us know that the successful endpoint of ART treatment is live birth, and this depends on various factors, including adequate number of follicles being stimulated, adequate number of oocytes being retrieved, and the quality of the oocytes. And this in turn is going to depend upon the protocols what we use, as well as the ovarian response. So there were several classifications which were poor ovarian response, and the first one was the Bologna criteria, which was published in 2011, and this was the ESHRE consensus. And then we had the Poseidon criteria, which was based on poor ovarian reserve and good ovarian reserve categories, and it was basically a patient-oriented strategies encompassing individualized oocyte number. And this was in 2016. And there was also a pivot classification, which looked only at poor prognosis patients, and this was done in 2019. So according to Bologna criteria, what is poor response? So what they said was that there should be at least two of the following three features, that is advanced maternal age more than 40 years, or any risk factor for poor ovarian reserve, a previous ovarian reserve, a poor ovarian response, where one has retrieved less than 3 oocytes with a conventional stimulation protocol, or an abnormal ovarian reserve where the antral follicular count is less than 5 to 7 and the AMH is anywhere between 0.5 to 1.1 nanograms per ml. They also had a supplemental criteria which said that there could be 2 episodes of poor ovarian response after maximal stimulation in the absence of advanced maternal age or abnormal ovarian reserve test. They also divided them into 8 subgroups. One was where no previous IVF attempt was there, and the age was more than 40 years, and there was abnormal ovarian reserve test. The second, third, and fourth were where one previous IVF attempt was seen and there was poor ovarian response. And this was then subdivided into where the patient was more than 40 years, she had an abnormal ovarian reserve test, or she was more than 40 years and also had more than an abnormal ovarian reserve test. And the other 4 groups were where 2 previous IVF attempts with poor ovarian response was seen. So they were again divided into when there was no risk factor for poor ovarian response and the ovarian reserve tests were normal. The second was the patient is more than 40 years with normal ovarian reserve test and abnormal ovarian reserve test, but there was no risk factor for poor ovarian response. And the fourth one was that the patient is more than 40 years and has an abnormal ovarian reserve test. But are these Bologna criteria ideal? And the answer is no, because it makes it difficult to manage the poor ovarian response groups using these criteria. So why are they not ideal? One is because there's heterogeneity of the subgroups, where you have young women less than 35 years with low ovarian reserve and with a previous episode of poor ovarian response, or they could be having normal ovarian reserve but have more than 2 episodes of poor ovarian response. The third group is where you have old women who are more than 40 years with normal ovarian reserve but still have a poor ovarian response. Second is there were specific profiles of abnormal ovarian response which were not included, that is the hypo or the suboptimal responders. And if you look at the various treatments given from 90 to today, we can see that when the patient is of the same age, BMI, and hormonal profile, we were using the same protocol. We were not changing the protocol. When the then came the at different ovarian reserves, and therefore we use different strategies, analogs and FSH starting dose. And the third, now what we do is where the patients are having the same ovarian reserve, but they have different sensitivity to FSH and LH, and therefore we change our FSH starting dose and may also add LH supplementation. And the third is that there could be age-related aneuploidy. So you can see that it does not depend upon the number of oocytes retrieved or the number of embryos you have, but it depends basically on the age. And for all the categories of the number of embryos or the blastocysts you have, the aneuploidy rate increases with age, as you can see over here. And we can also see that with different number of oocytes obtained, age really makes a difference, because the even with lesser number of follicles, the live birth rate is higher if the age is less than 34 years, and it decreases as the age increases. And this is not only true where you have less number of oocytes, but also where you have more oocytes, and even if you have more than 23 oocytes, which we get in our PMOS patients. And therefore, now what we look at is patient stratification according to the ovarian response. The poor is where we have 1 to 3, suboptimal where we have 4 to 9 oocytes, normal when we have 10 to 15, and hyper response when we have more than 15 oocytes. And therefore, we changed a strategy from poor responders to low prognosis concept. And this was basically based on the ovarian biomarkers, AMH and the antral follicular count, which have a good accuracy for prediction of low oocyte quantity. The number of oocytes retrieved if previous ovarian stimulation cycles are performed, and there's a strong association between the oocyte quantity and the cumulative live birth rate, as well as the age, which is going to tell us not only about the quantity, but also about the quality of the oocytes. And therefore came in the Poseidon group, which looked at the low prognosis groups. And what they said that the poor ovarian response must be categorized by age and ovarian reserve. So you have a good ovarian reserve, but then you have both young and old poor responders. And when you have poor ovarian reserve, you have old as well as young poor responders. And therefore, this classification divided the patients into 4 groups. The group 1 and 2 were those who had unexpected suboptimal response, and the prevalence rate of this was almost 43%. So the group 1 was less than 35 years, having an antral follicular count of more than 5, AMH of more than 1.2, and this was further divided if they had a previous IVF into 1A, where they obtained less than 4 oocytes, and 1B when they obtained 4 to 9 oocytes. Whereas the group 2 was when the woman was more than 35 years and the antral follicular count and AMH was normal. And this was again further divided into subgroup A and B, depending upon the number of oocytes obtained in the previous cycle, that is less than 4 or between 4 and 9. And then you had the group 3 and 4, which where we expect a poor response. And in group 3, the age was less than 35, antral follicular count less than 5, and AMH 1.2, less than 1.2 nanograms. And here, basically, quantity is the issue. Whereas in a woman who's more than 35 years in group 4, having an antral follicular count of less than 5 and AMH of less than 1.2, here not only the quantity, but even the quality could be an issue. So basically, if you look at the aneuploidy rate, the group 1 and 3 have a lower aneuploidy risk as compared to group 2 and 4, which have a high aneuploidy rate. But all of them have fewer embryo generated, and this is associated with reduced cumulative live birth rate. So what we look at in these patients basically is the follicular oocyte output ratio, which is a ratio between the pre-ovulatory follicles following ovarian stimulation and the pre-existing pool, or a small antral follicular pool, and describe it as low fourth or follicular output ratio when it is less than 30 or 40%, and this basically signifies a hyporesponse. So here you can see the patient has a good ovarian reserve, but the number of follicles, pre-ovulatory follicles she has is considerably lower, that is less than 30%. And you have this patient who just has about 5 follicles, but has 3 mature follicles or large follicles, and therefore she has a good ovarian response. The other index what we look at is the follicular to oocyte index, which is the oocyte number upon the antral follicular count multiplied by 100. and it is normal if it is more than 50%, and we say that it is a good response with normal and low, both normal as well as low ovarian reserve. But the FOI is less than 50%, we say it is poor ovarian reserve, and it could be with normal or low ovarian reserve. So we must not consider only decreased ovarian reserve patients as poor responders, but also look at those patients with normal ovarian reserve who are hyporesponders. I would not dwell much on the pivot prognosis, which only looked at women who were more than 40 years or had repeated implantation failures, or who required a higher, generated less number of oocytes with a maximum dose of 450 IU daily. And all these cases basically could also result in poor quality embryos. So when we talk about hyporesponders, they basically have hyposensitivity to FSH, and they are basically young, normogonadotrophic women with normal ovarian reserve who show suboptimal or unexpected poor response to exogenous FSH. They tend to show an increase in cumulative FSH dose of more than 2,500 or 3,000 IU, and the stimulation length also is greater. And they are characterized by initial slow or poor response to recombinant HCG. They have a normal follicular cohort with no follicles more than 10 millimeters on day 8 of stimulation, or there is stagnation of the follicular growth between day 7 and 10. The incidence is about 15%. It reflects hyposensitivity of the granulosa cells to standard FSH dose and is associated with high FSH consumption, low FORT, unexpected poor response, and low pregnancy rates. And if identified earlier, that is between day 5 and 8 of control ovarian stimulation, one could add LH activity, and we could rescue the follicles and the oocyte number as well as embryo competence. So the causes of a poor response in Poseidon 1 and 2 could be polymorphism of FSH and LH receptors, exposure to environmental toxins, oxidative stress, and excessive free radicals, low gonadotrophin starting dose, asynchronous development of follicles, and trigger, and there could be problems with trigger and oocyte pickup. Whereas Poseidon 3 and 4 is basically due to low ovarian reserve and age-related decrease of ovarian reserve, especially in group 4. So what is new basically? We have identified having a concept of low prognosis in ERT. We are looking at combined oocyte quantity as well as quality. We included hyperresponders and also introduced an intermediate market of success in ERT. So what is the success? In Poseidon 1, we should get at least 5 oocytes to have 1 euploid blastocyst. In 2, we have to have 10 to 12. In 3, about 4 to 7. And in 4, about 12 oocytes. And we know that retrieval of less than 4 to 9 oocytes is usually associated, as you can see over here, with significantly lower live birth rate, even when we stratify them by age, and as you can see over here. So the challenges basically are asynchronization and oocyte yield, premature luteinization and ovulation, and low oocyte quality and aneuploidy. And then the question is whether we can increase the oocyte yield or improve the oocyte quality. So basically what we need to do is to identify this low prognosis patients and stratify them according to the Poseidon classification, calculate how many oocytes we need to obtain at least 1 euploid embryo, and increase the follicular synchronization and sensitivity to FSH. We have to plan the treatment, individualize the treatment, and in Poseidon 1 and 2, we have to optimize the ovarian response, and 3 and 4, we have to maximize the ovarian response. And for this, we have to have a good counseling, set patient expectations, and discuss the alternatives. Donor side options may be offered to group 4. And the best management is to improve the FORT, improve the FOI, and increase the responsibility, recruitability, as well as growth of the follicles. And for this, we may increase the starting dose, use recombinant FSH, add LH activity. We have to choose a proper analog. We have to look at the trigger strategies where probably a double or a dual trigger may be helpful. Probably add adjuvants, and also pre-treatment may be useful. We have to look at the embryo transfer strategies, whether we should go for a fresh or a frozen, and luteal phase as well as personalized use of the lab. So I would conclude by saying that the Poseidon classification allows for individualized management of poor responders in ART, considering both age as well as ovarian reserve. Management should be tailored to each group, focusing on maximizing FOGSI yield by setting realistic expectations. Adjuvant therapies and novel stimulation protocols are promising but require further evidence for widespread adoption. Low quality is not always low quantity is not always low quality, and this heterogeneity is primarily determined by the woman's age, reflecting the importance of suicide quality. The low responder is not always poor, the old ones are, and the cumulative live birth rate vary between the Poseidon groups, and personalized approach to COS tailored to individual characteristics of patients will ensure patient-centered and evidence-based approach that should optimize the fertility outcome. So we can say that in poor responders, there's always light at the end of the tunnel, with new modalities of treatment being investigated with larger RCTs. And I thank you all for a patient hearing.
Thank you very much, Dr. Madhuri Patil, ma'am, for being here with us, and apologies for the poor quality of the transmission. I think it's in traffic, but she honored her commitment. We really appreciate your being here.
Thank you. Thank you, Madhuri.
Yeah. Because I'm not sure what time I'll reach.
Bombay
So
and
as
Bangalore traffic are similar.
battery goes up, I better make the presentation.
Thank you. Can I request the chairpersons to introduce our next speaker, Dr. Sanjeeva Reddy? He's been logged in for a while. And thank you, sir, for adjusting and accommodating the change in the schedule.
Welcome, Dr. Sanjeeva.
Dr. Shaili Nigam, would you like to do the honors?
Very good evening to everyone. It's an honor to introduce our next speaker, Professor Dr. N. Sanjeeva Reddy. He is former professor and HOD Department of Reproductive Medicine and Surgery in Chennai. At present, he is the Managing Director, Senior Consultant Reproductive Medicine and Surgery, Royal Hospital, Chennai. Academically, he started the first super specialty course in OB/GYN India. He has a lot of awards to his credit, very actively, extracurricularly also, and I request sir to proceed with his talk.
Dr. Sanjeeva is one of the few BC Roy awardees that we have, and he's a very eminent teacher. He helped us also to conduct the first 1-year ICOG reproductive medicine exam just a few months back in February. Thank you for all your contributions to ICOGs.
At the outset, I would like to thank the chairperson, Dr. Sheila Mane, and secretary, Dr. Pratik Tambe, for involving me in this program. Today, I was asked to speak on treating anovulation. Anovulation is defined as when a woman's ovaries fail to release a mature egg during a menstrual cycle, preventing fertilization. Ovulate disorders account for 18 to 25% of infertile women. The ability to induce ovulation at attain pregnancy in anovulate infertile women remains one of the greatest achievements in reproductive medicine. The goal of ovulation induction is development of a single follicle and subsequently ovulation in women with anovulation. WHO classification of ovulation induction, there are 3 groups, and some say there is 4th group also there. Group 1, hypothalamic pituitary failure, it constitutes of 5 to 10%. Group 2, hypothalamic pituitary dysfunction, it will constitute maximum like 75 to 85%. Mostly it is PCOS women. Group 3, it is ovarian failure, it constitutes around 20%. And 4th group, if we include, this is hyperprolactinemia, it constitutes around 5 to 10%. There is another corporation recently released by FIGO. Here, what they have done is they have constituted 4th group for exclusively for PCOS patients. So first, any patient comes to you with anovulation, it is on our part to find out under which group this patient will come. Any disease, detailed history, and thorough examination important. After that, you do the 2 things, the FSS and prolactin. This will help us to come to a conclusion. If the FSS is low, then we have to see her body weight and pituitary imaging to exclude any pituitary problems or anorexia nervosa. If these are normal, then hypogonadotropic hypogonadism, this will come under group 1. If the FSS is normal, here also you have to check the body weight and pelvic scan to exclude the PCOS or PMOS. Then we will call it non-gonadotropic anovulation. It will come under group 2. If the FSS is increased, so that is ovarian failure, we have to do whether it is of genetic origin or immunological origin, karyotyping or autoantibodies we have to do. So this will call as hypergonadotropic hypogonadism. This will come under group 3. Fourth is if it is prolactin is increased, so we have to exclude any pituitary tumors are there. That's why imaging of pituitary is important. Almost always we have to exclude any thyroid problem is there in these things. If these are normal, then we will call it as hyperprolactemia. It will come under group 4. And we will see how to manage these patients. So if it is group 1, here there are 2 types of management is available. Pulsatile GnRH therapy, we'll use the infusion pump. Here, 15 to 20 micrograms given subcutaneously every 60 to 90 minutes. The ovulation rate will be around 80%. Advantages, no monitoring is required, less risk of OHS, but the multiple pregnancy rate also is very less. The disadvantages, inconvenience of wearing pump, limited patient acceptability. Next is gonadotropin therapy. Here, HMG, recombinant FSR, recombinant LH, priming with estrogens and progesterone important in these patients. Start with low dose of 75 U, and if needed, we can increase up to 225 U in these patients. There are 3 ways you can give: conventional step up, low dose step up, or step down thing. In conventional, we'll start with 75 U and increase 75 U after 7 days. Then after 3 to 5 days, we'll do the scans. If there is follicles are not that much improved, then we'll be increasing this thing. Low dose, so particularly if we are suspecting PCOS patients, or in case of like hypo, it takes longer time to respond. That's why start with a low dose like 25 to 50 IU, increments of 25 to 35, 7.5 after 14 days. Then every 7 days we'll be increasing these things. In step down protocol, as you know, whatever amount of gonadotropin is what you will give, the follicles, what it starts growing in the beginning, so that only is going to go. So here we'll start higher doses, 150 to 225. Then after 5 days, then you do the scan. If the follicles start growing, recruited, then you can reduce by 37.5 IU. This way you can go. So with this therapy, and always patient needs trigger with HCG, and luteal support with micronized progesterone is essential. Cycle fertility is 25%, and cumulative pregnancy rate is 90% over 6 cycles. And ovulation induction group 2, that is PCOS patient mainly, we have oral agents and injectable agents. Oral antiestrogens, clomiphene citrate, tamoxifen, and insulin sensitivities like metformin, N-acetylcysteine, and D-chiroinositol. And aromatase inhibitors like letrozole and anastrozole, and injectables, urinary, recombinant, and GnRH analogs also is available. So first, the drug of choice is the clomiphene citrate, non-steroidal diphenyl ethylene derivative. Both estrogen agonist and antagonist action is present, found in serum up to 30 days. The usual dose is 50 milligrams. So day 2 to day 5 you can start. Usually the ovulation will occur after the last tablet. 5 to 7 days later, we'll start doing the scan here. So here the starting dose will be 50. Like in some patients, if it's not responding, next cycle will be going to 100. And there are so many people, they will be telling up to 250 milligrams. But if you see this table, up to 150 milligrams, it's more than 85% of patients will ovulate, and also more than 80% of patients will conceive. That's why the FDA recommends maximum dose of 150 milligrams per day, because it is having an anti-estrogenic effect. If you give more than that, even though patient ovulates, the patient may not conceive. How long we can give? A maximum of 6 months consecutively if you are giving, or 12 months in a patient's lifetime. Suppose if you are missing some intermittently, if you are giving, maximum 12 cycles. 75% of conceptions occur within the first 3 months. If the patient is not considering 3 to 4 cycles, better to go for the next step. So the ovulation rate will be around 80%, pregnancy rate will be around 40%, teen pregnancy rate will be around 7%. There is 15 to 20% of patients, they won't respond. There are two types is there, clomiphene resistance, failure to ovulate with maximum dose. That is, if you decided to 150 milligrams, patient is not ovulating, we will call it as clomiphene resistance. Clomiphene failure, patient ovulates, but she won't conceive, we'll call it as clomiphene failure. So how to manage the patient who fail to clomiphene? There are two varieties available here also, medical and surgical. Medical oral agent, clomiphene, and metformin, dexamethasone, letrozole, these can be combined with these three. Or injectables like gonadotropins, or sometimes if needed, we will use the GnRH analogs also. The surgical treatment is ovarian drilling. So here, clomiphene itself, usually in an unovulated patient, what we will be doing, we will be giving like 50 milligrams and we'll do the scan. If there is no follicle develops, we'll cancel the cycle. Next cycle, we'll go for the 100 milligrams. Like this, we'll be doing. That takes longer time. Patient also won't be having patients will go off like that. Instead of that, there is one stair-step protocol. Here, we'll be giving 50 milligrams for 5 days. Then after 1 week, we'll be doing the scan to see follicular fluid is there or not. If the follicle is recruited, then we'll continue. If suppose it's not there, again you can give the 100 milligrams of clomiphene citrate for 5 days. Then after 5 to 7 days, we do the scan, see the whether follicle is developing. Suppose there is no follicle, then we can go for the 150 milligrams. The same cycle we'll be giving. The total time taken for this type of things, we'll know in one cycle itself the patient is going to respond to your clomiphene citrate or not. In 28 days itself, we'll know. Traditionally, like suppose every month if you are going to increase, it takes more than 3 months. And they compared the pregnancy rate also, there is not much difference in the pregnancy. The clinical pregnancy rate is 13% versus 15% in conventional protocol. So in stair-step, it is up to 13%. So we can go for the stair-step protocol also. Next is intermittent clomiphene therapy. Here what they have done is, instead of increasing after 1 week like that, there is no follicular thing. What they have to give the 500 milligrams of clomiphene citrate 5 days. After 1 week, you do the scan. If there is no follicle development like recruitment, give the same 100 milligram again for 5 days. Then after 1 week, you do the scan. You just see whether follicle is recruited and started developing. Then if it is developing, you continue the same thing. Otherwise, again, you give the 100 milligrams for 5 days. So with this, patients are given. So if you see the results, in the first cycle itself, around 11-12% patient conceived. In the second thing, so around more than 50% of patients conceived. The third, like intermittent time, when they are continuing this patient, around 55% they conceived. So the total, so around 80% of patients are conceiving with intermittent clomiphene therapy. So we can try this type of thing also in these patients who are resistant to clomiphene therapy. Next is aromatase inhibitor. So you will letrozole, 2.5 milligrams for 5 days. We'll give like same way like for clomiphene citrate from day 2 to day 5. We can start. Suppose if the patient is not responding, then next cycle we will be increasing 5 milligrams for 5 days. The maximum dose you can give is 7.5 milligrams only like that. If you go beyond 75 milligrams, one side effect of this one is thinning of the endometrium. So even though some patients may develop the follicle, but the endometrium will become thin, patient may not conceive. So the ovulation rate with letrozole also will be like same way like that, up to 80%, and the pregnancy rate also around 25% per cycle in PCOS patient resistant to clomiphene citrate. So comparing with clomiphene citrate, there was no significant in ovulated cycles or pregnancy rate per cycle or pregnancy rate per patient. It's almost same only with life. Next is suppose patient is not responding to like this 2.5 or 5 milligrams. There is another variety also, the extended letrozole therapy. Here, what we will be doing there, instead of 2.5 milligrams for like 5 days or 5 milligrams for 5 days, they continue 2.5 milligrams per 10 days. And in another thing, they compared with the 5 milligrams for 5 days only. So here, the ovulation rate with extended letrozole therapy was 75% when compared with around 55% with the short letrozole therapy. And pregnancy rate also is around 24% when compared with the short letrozole therapy like that. So this also we can go try if the patient is resistant to clomiphene citrate. Next is if this not responding to these things, then we have available second line, we have to go for the gonadotropins or surgical like ovarian drilling. Here we'll discuss about the gonadotropins. We have step-up protocol, high dose or low dose, step-down protocol, sequence of step-up and step-down regimens, and clomiphene and gonadotropin cells combination also they will be trying. So here, so like conventional step-up like that, we have already discussed here. If for 5 days, then the 8th day, just do the scan, see whether the follicle is developing or not. The follicle is developing, continue with the same dose, then alternate day like that you can do. Then if the follicle is not developing properly, then you can do the estradiol estimation also and increase the dose. When the follicle reaches around 18 to 20 millimeters, you can trigger. Low dose, if you are case of PCOS patients, this is like all or none phenomena, when you are giving the gonadotropins, so it may not be responding. Suddenly, if you increase like that 75 to 150 or thing, all follicles at a time will come. So like that, for that sake, they will start with, you can start with a lower dose, step by step you can go, and same way you can monitor. Step down protocol, here, this is very useful in case of low responder patient or low reserve patients. Here also same way we will be going. Next is the results with the gonadotropin says ovulation rate will be around 67%. Pregnancy rate in 5 cycles, cumulative pregnancy rate will be around 47.7%. Teen pregnancy around 11%. Age less than 35 and BMI is less than 30. Patients will respond better. There the older patients and the BMI is more patients. Next is the surgical induction of ovulation, laparoscopic ovarian delivery. See, gonadotropins, one problem is patient has to come daily. She requires intensive monitoring. Otherwise, there is a chance that she can develop OHS. Here, surgical thing, if the patient is not able to come, or some of the indications like a woman BMI is less and LH is very high. These patients, even if you give the gonadotropin, she may not respond. And this type of patient you can select for the ovarian drilling. So what you have to keep in mind is there is a chance that these patients can develop peri-ovarian adhesions, and also if they are not following the proper precautions, there is a chance there her ovarian reserve can be decreased, and some people they can go for the premature ovarian failure also. With laparoscopic drilling, the ovulation rate will be like varying from 50 to 70%. The pregnancy rate in CC-resistant PCOS patients, women will be around 67%. So the management of ovulated disorders, in group 1, we will have the gonadotropin GnRH analogs. If the patient is ovulating earlier than the follicle mature, there you can try these things. Like if you're giving GnRH antagonist, so we can wait until the follicle matures, then you can give. And group 2, we have CC and metformin. Suppose if you combined with the clomiphene citrate metformin, the ovulation rate will be better and pregnancy rate also will be better. Or you can go for the PCOS patient, particularly you can go for the letrozole. And if it's not responding, then you can go for the gonadotropins. If the patient is having group 3, so here only option available is donor oocyte program. If it is increased prolactin is there, that is hyperprolactinemia, we will go for the bromocriptine or cabergoline. These are the things. Thank you.
Thank you, Dr. Sanjeeva, sir. Excellent presentation addressing all the important protocols in a very short space of time. I would request Dr. Akhi to present closing remarks and then introduce our next speaker, Dr. Sonia Malik.
Thank you, Dr. Sanjeeva ma'am, for very practical and practice-oriented presentation. Thank you so much, sir. And if any, please, I would request you to answer the questions in the chat box. There are a few questions from the audience.
Thank you. Backend team, can we have the presentation of Dr. Sonia Malik, ma'am, please?
Next, I would like to invite Dr. Sonia Malik. Ma'am needs no introduction. She is currently Chief Clinical Mentor at Mobile Infertility. We request you to ma'am proceed with your presentation.
So we started off today's entire program with an excellent video demonstration of tubal fertility, and there were several questions regarding diagnosis of tuberculosis. We have the oracle herself, Dr. Sonia Malik, who's going to talk to us about front cancer. So over to you.
Thank you so much, Dr.
Welcome,
Sheila.
Madam Ji.
Thank you so much, both of you, for having me here today. I don't know, I haven't even on this thing. I haven't. Anyway, I would start rather than wasting time. My screen is visible to all. So, yes, Dr. Prateek, I'm talking about infections, but not tubercular infection. It is slightly different. So first, this presentation will actually address chronic endometritis, which is something which has come in very recently, and how to diagnose and manage this chronic endometritis. So by definition, it means that there is a slight inflammation in the endometrium, and actually it is agreed that it is the plasma cells which help us to diagnose this. But of course, many a times we miss it only if we are looking at plasma cells. So we have started thinking of other modalities in order to diagnose this condition. And Indian studies, interestingly, show an incidence of 15 to 57% of the cases. This is very much like what we had in tuberculosis. There was a very big variation in the number of cases that we were seeing in our practices, and that was probably because of the method that we were using to diagnose it. So similarly over here, it is also said that there is sometimes a clinical inflammation. There is subclinical inflammation which may have been caused by other causes, and that also leads to that also presents as chronic endometritis. We shall talk about it as we go on. Uterine microbiome is coming up as a very big factor in all diseases everywhere, and also this is said to be prevalent in cases of repeated implantation failure, recurrent pregnancy loss, and also in repeated IVF failures. And interestingly, this slide is from ICMR, where they have actually diagnosed that 25% of our cases have chronic endometritis. So how do we actually diagnose pelvic infections? Again, this is an article by Neeta Singh from AIMS, where she says that, we are looking at specific things in order to arrive at a diagnosis: histopathology, hydrosalpinx, which may be present with free fluid or not, MRI, Doppler studies suggesting inflammation. Of course, hysterosalpingography is not indicated in acute infections, but we do it in chronic, and hysteroscopy, which is again not recommended when you are but today we are looking at chronic inflammation. So laparoscopy also with proven signs of PID. So these are some of the clinical markers or clinical features, clinical methods by which we diagnose pelvic infections. And what are the microbes that we are looking for? We look at the number of the listed microbes in this article, where she says aerobic and anaerobic bacteria, what are we looking for? Also, pelvic inflammatory disease, the findings generally are Neisseria gonorrhoeae and chlamydia, elevated ESR, CRP is elevated, abnormal cervical discharge, abundant WBC, and of course fever. These are all features of acute endometritis. But what happens in chronic endometritis? It's very different because the organisms which are located or detected in the endometrium are different. We have the E. coli, streptococcus, enterococcus, and staphylococcus. But most importantly, we have the mycoplasma and ureaplasma and Gardnerella, which may be present in these conditions. Klebsiella is also found. So you can see over here that the list is nearly as large as you find in acute endometritis. But the only thing is how to locate this, how to find all this. So that is why we are always in a kind of a soup where we want to understand what is this, what are these conditions of infection, yet we cannot put our finger on them. So also was the case with Mycobacterium tuberculosis. So, but interestingly, what we all have to understand now, these 2-3 slides are very important to understand how infections work in our body. We have to understand that the hormones are the main players. They are actually causing a cyclic change in the endometrium. And as a result of that, the immune system responds, and you have different kinds of cells which are upregulated and downregulated in the proliferative phase and in the luteal phase. If you look out here, these are the ones which are under the influence of estrogen. They are different set of cells, the cytokines. And here you have a different cytokine, different kind of cells and cytokines emerging as a result of progesterone. So also happens to the microbiome. It is changing. It is different in the proliferative phase and different in the secretory phase. So that is why when you are taking a biopsy in a patient, it is very important to understand in which phase of the menstrual cycle you are taking a biopsy to understand infection. Or in endometritis, whether it is chronic endometritis non-specific or whether it is tuberculosis, because basically these cells are varying and therefore the response of the endometrium is also going to be different. This is something very basic that we all have to understand. And here is another very interesting article which tells us how infections actually happen within the system and what happens to chronic infections. There are two kinds of happenings that happen in the endometrium or in the genital tract. First is the microbes pathogens. So this is called PAMPs, or pathogen-associated molecular patterns. You may have found this in one of the clinics from Delhi, where she's always talking about PAMPs when tuberculosis is to be diagnosed. So this is basically a pathogen-associated molecular response. And the other is called DAMPs, which is as a result of trauma, foreign bodies, ischemia, etc. This is DAMPs. So these are two different entities, and they both result in the same kind of response inside the tissue. So there is a release of pro-inflammatory cytokines, vasodilatation, increased capillary permeability, immune cell migration, all that happens. And then there is the adaptive immune system, which gets activated with both these things, remember. And that is how then there is a release of pro-resolution cytokines, and finally everything gets resolved. So therefore, this is how the infections are dealt with in the body, and this is how also inflammation is dealt with in the body. So there we have to be very careful in what we are dealing with, whether it is actually infective or non-infective inflammation. So then again, same article also goes ahead to tell us how chronic inflammation happens. Either it is a long-term exposure to the same factor, or it is a recurrent acute inflammation, or it is a failure of pro-resolution pathways of inflammation. So these are the three pathways by which we are actually seeing what is happening inside the uterus, whether it is actually presenting as acute infection, acute inflammation, or chronic infection, depending on whether the tissues are destroyed, whether there is actually granuloma formation, and how is it actually resolving the insult that it is receiving from various organisms and various factors. So then quickly let us understand the clinical markers. We are looking at ultrasound scans, HSG, like I said, hysteroscopy and chromohysteroscopy, which is coming up very fast now. We all know these features of ultrasound. Out of phase endometrium shows irregular broken endometrium. There may be calcification also, which is very common in tubercular endometritis, also thick irregular endometrium, which may be found. And so also radiology, most of these you would have seen, because this is a very famous radiology picture which appears in most of the presentations. This is for Asherman's, and you find all these things happening in chronic inflammation in such cases. But what has happened is that we have actually identified diagnostic criteria for chronic endometritis on fluid hysteroscopy, and this is basically now the standard method that has been the standard classification that we know of, and this was actually given in the year 2019 by a group of hysteroscopic surgeons. And what they said was, if you have hyperemia, if you have strawberry spots, micropolypi, scarring and adhesions inside the uterus, then you should think of something like endometritis within the uterus. And this is something that we very commonly see when we are doing our hysteroscopies, and then you take a targeted biopsy from them to understand whether there is chronic endometritis or not. And this is specifically for tubercular endometritis, the adhesions, the spotted endometrium, and the fibrosis that you find in these patients. And so you can make a diagnosis of chronic endometritis, specifically tuberculosis. So, but then, is this enough? So they went a step further and they started putting some color in it and then trying to see whether this is more helpful in detecting chronic endometritis or just a plain hysteroscopy. And what they found was that with this, the percentage of abnormal, the percentage of abnormal features that you found, or whatever the chronic endometritis that you found with the stained, was about more than what you found in the unstained one. So you pick up many more cases of chronic endometritis when you're staining the uterus rather than keeping it unstained. Similarly, when they compared fractional curettage to chromohysteroscopy, again they found that the number of cases that they find with color inside is much more as compared to just a plain hysteroscopy. So now we generally do a chromohysteroscopy when you are looking at endometritis or suspecting endometritis. This is another beautiful paper from the Egyptian group in 2024, where they compared again whether they want to, what happens to the uterus once you put color in it. So they found a focal dark pattern and a diffuse light pattern. Two patterns when you put the color inside or you chromatograph the uterus, they found that there was a difference. And when you are having a focal dark pattern, they found that the endometrial pathology was much more as compared to the diffuse one. And this had a much better sensitivity and specificity. So even in this, even if you look at the endometritis as such, if there is a focal dark pattern, only 5%, and diffuse, they found it 17.2% in this particular cases. So hence, what we can say over here is, finally, to actually understand this whole hysteroscopy evaluation, we should use color, and if it is darkly stained, also it is significant. But of course, you have to look at the sensitivity and specificity of what you are trying to look for. Now, the final diagnosis always comes from cellular histopathology and from these what is inside the cells. It's not just what we visualize. So the actual method by which we are looking at chronic endometritis is by looking at the CD138 by immunohistochemistry, although we were initially looking for it on the H&E stains by an asynchronous stromal granular appearance. Endometrial eosinophils also increase, but most importantly, the plasma cells were the ones which tell you whether it is chronic endometritis or not. However, confirmation comes when immunohistochemistry tells you that CD138 is positive. And this is again that the same slide which I had showed you earlier. 25% of cases of infertility, according to this ICMR report, has 138 positive, and therefore chronic inflammation is fairly common in our population. Now, the role of endometrial microbiome, like I said, has become very, very important. I'm moving on to the molecular tests now from the clinical tests that we do. And in my endometrial microbiome, the analysis of 16S ribosomal RNA, which is the standard method of looking for microbiome in any kind of tissue, they found that this actually impacts the reproductive outcome in infertile patients. And this is a beautiful paper which appeared in 2020. It gives a glimpse of the endometrial microbiome in an early pregnancy. Here they looked at the metagenomics of endometriosis, of the microbiome in a patient of pregnancy. In the same patient, in a subsequent pregnancy, when she was aborting, they again looked at it and they found that the microbiome was totally different from the time when she had carried on with the pregnancy. So this is a continuum kind of a thing. In over were 2 pregnancies in the same patient where one carried on and it was a successful pregnancy as against one where she had a miscarriage. You can see over here that the microbiome changes when the patient is going to abort. And they also said that, you know, they looked at the functional metagenomics also, and they found that lactobacillus species crispatus was the one which actually was increased when she was going to miscarry. So this is a beautiful paper that tells us how the microbiome also influences the endometrial environment inside and causes miscarriages. Again, coming to the Indian context, because Pratik had told me I have to talk about the Indian aspect of it. These are some of the beautiful papers that I could come across. This is an Indian paper from 2024. This is from the Life Cell group, the Life Cell lab. They have actually done a multicentric study of their samples. And what they have found is that they used, very interestingly, we have come back again to polymerase chain reaction. That means we are again coming back to real-time PCR in this also. And they have used this very effectively to pick up the microbiome or the microbiota in the endometrium. And these are the primers that they formed against all these organisms which are known to affect the endometrium in chronic endometritis. And they looked at chronic endometritis in 3 conditions: abnormal bleeding, recurrent implantation, and pregnancy loss. And what they found was that, yes, this is extremely helpful, much, much better than just hysteroscopy and microbial culture, where the sensitivity was 61% only as compared to the molecular diagnosis where it was 100%. We all know that PCR is going to... And that is it the bell which tells me that I have to finish? Is this something like that? I've been hearing it each time. Anyway, so again, based on what they had found, they also looked at the pathogen-specific treatment. And actually, according to the gram-negative bacteria, gram-positive, mycoplasma, ureaplasma, etc., these were the antibiotics to which they were sensitive, and giving them very specifically according to what organism was found gives rise to much a better prognosis, much better results in our patients of pregnancy losses. Yet another good paper, again from another group from Rajasthan, talking about the same thing. They looked at the histopathology diagnosis, the microbial cultures. Of course, they did not do the PCR in this because that is not a standard thing that we are doing. But they also did a gene expert in these, and they found that, of course, they found some cases of tuberculosis also in these. And they also looked at the frequency of the positive and negative as compared to the histopathology also. And they found that positive were 9 only in a frequency of 74 and negative were 65. So it's not such a high incidence, but yes, definitely we do get lots of patients having CD138 positive. This is a small paper that we have published also, not too many cases, just about 56 cases. We found it positive in RIF in 24.5% and in infertility in 14% of our patients. But interestingly, there was a disordered proliferation plus CD138 positive in 22.5%. And remember, I told you that there is a subclinical infection in some of these cases, which may be responsible for this picture of endometritis, but it is actually non-infective endometritis. So this was what we found, that it is also positive in these cases. We followed it up last year. This is the data from 2025. We are doing CD138 for all patients who come to us for infertility. It was positive again in 33, 24.4%. And out of these 24.4% patients, hormonal dysfunction was found in out of these 33 in 9 patients. In 9 patients, 6 had proliferated mild disorder. In mild endometritis, they had disordered proliferation in 6, and in the moderate, there was 1 patient who presented with disordered proliferation. So in all, we had 7, and so 27% showed, similar to what we had found in the earlier paper also. Here again, interestingly, Mycobacterium culture was positive in 4 patients, and PAMP, like I said, one of our labs in Delhi uses this terminology. So this was positive in 2 patients, which is about 5% of the total 102 negative patients. So therefore, it is important to know that yes, we are having these patients of chronic endometritis, and we do need to look at them as well. So this is again reiterating what I had told you in the beginning, that there is an impaired inflammatory state in the endometrium. This is called IISE, a new terminology that they have come up with, called impaired inflammatory state of the endometrium, which actually suggests chronic endometritis, infective as well as non-infective. So if you have a patient of disordered proliferative phase, indicating an out of phase endometrium, you should be suspicious of inflammation of some kind. It may not be infective. It can be just that this is some kind of a non-infective organ pathogenesis also. So coming then to the management, it's not difficult. Any infection has to be treated by giving antibiotics. We know that. Microbiome, if we have been able to detect it, very good. Otherwise, we are always giving probiotics and prebiotics again, and hormone imbalance has to be corrected. So the very common treatment that is given is doxycycline, 100 milligram twice a day for 14 days, and persistent positive biopsies are retreated with a combination of ciprofloxacin and metronidazole for 2 weeks. I generally give us an antibiotic for a month and then do a repeat biopsy after that. Intrauterine infusion of 3 to 4 ml of ciprofloxacin can also be given. This was, in this particular paper, it was given every 3 days for a total of 10 infusions. We are generally giving it basically not injectable but oral, and all of them are suspected. But if I find 2 biopsies still turning positive, I generally consider her as something that we have missed. So we redo a biopsy to look for tuberculosis. Generally, we find that we have missed a tuberculosis in that case. So this is the first meta-analysis that has appeared on this subject, and this was in 2022. Unfortunately, I could not find access to the full text, but what it said in the summary was that patients with cured chronic endometritis after oral administration of antibiotics had a significantly higher clinical pregnancy rate, implantation rate, and continued live birth rate as compared to patients without endometritis. Patients with persistent chronic endometritis after therapy had a significantly lower implantation rate, clinical pregnancy rate, and live birth rate as compared to those without. And then patients cured with chronic endometritis had a significantly higher everything as compared to the persistent one. So essentially, what this meta-analysis does tell us that chronic endometritis exists, and if we give adequate antibiotic therapy, it gets cured also. So this is basically the paper from the Carlos Simon's ERA group, where they are actually looking at Emma and Ellis. Some of you may be getting this test done also when you're getting your ERA done. They also showed that when you give antibiotics and give probiotics, they had also definitely insisted on giving antibiotic followed by probiotic, the implantation improves, the clinical pregnancy rate improves, and the ongoing pregnancy rate also improves in these patients. So definitely there is a point in looking for infection and then treating it adequately. Coming then to chronic tubercular endometritis, we all know there are standard regimens for new TB patients, the intensive phase and the continuation phase, 2 months of all 4, and then 4 months of just 3 of them. And then, of course, the dosage is as is given over here. This is standard treatment by the Government of India, and we all have to follow this even for that. We all know that it is now a notifiable disease. So what about, so therefore, the big, large question is, does it actually change the outcome for IUI and IVF patient? There is a confusion. There is a debate still. Some people still believe, like I said in that meta-analysis, it comes out that yes, it does help, but there are patients who have also not benefited by treating the chronic infection. So definitely there is much more to it than meets our eye. And we do need to deep dive into what is happening inside the endometrium, trying to understand where it is, where this is all coming from. So thank you very much. Just to conclude, I would say that chronic endometritis is a very subtle condition. It affects the uterus and causes recurrent implantation failure in ART. If it is recognized and timely treated, it gives positive result. There is a definite need to change our attitude and start looking at chronic infections as a cause of pregnancy failure. Infections are something that we have ignored for a long time. Now we are keenly looking at them, and I think we'll do much better when we treat them at first. Thank you all very much for being with me. Thank you so much.
Thank you, Dr. Sonia Malik, ma'am. Exhaustive presentation, and in a short period of time, you covered all the different types of both acute as well as chronic endometritis. My gratitude to the chairpersons Dr. Vatsala Kamath, Dr. Rajiv Goyal, and Dr. Shalini Nigam for doing the honors for this session. We are already delayed by about 18
I
minutes.
just want to say, madam, excellent talk, madam.
Thank you, Dr.
Exhaust you, but so much of enlightenment. बहुत ही अच्छा. Thank you.
And thank you for waiting and accommodating Dr. Madhuri Patil. Thank you very much. So we'll proceed to the panel, which is going to be moderated by our convener for today, Dr. Seema Pandey, along with Dr. Sunita Arora, who's a past chairperson of the Delhi ISAR. We have a fantastic group of both young as well as senior experienced panelists who are going to serve as panelists as well as experts. And for this, I will hand over to the moderators to do the honors and introduce. Seema, please take over. You are muted. I have sent you an unmute request.
No, hello, can you hear me?
Yeah, we can hear you now. Go ahead.
Thank you, Prateek. So we'll start with the panel. Can I share?
Want to introduce the experts and the panelists quickly?
Okay, yeah, please. Dr. Sunita is my co-moderator. And as we all know, she's from Delhi, currently director at Dr. Sunita Arora Fertility and Gynae Clinic at Safdarjung Enclave, head of department at Fortis Hospital, and she's been was past president Delhi State Chapter last year, and she had received so many awards and accolades. Welcome, Sunita. And our panelists, experts are Dr. Archana Basair, who is Vice President FOGSI 2020, Chairperson MPSR 2527, Fellow Representative AICC RCOG West Zone, and Joint Secretary SPAT 2527, and she is Organizing Secretary. She was AICOG 2021. So welcome, Dr. Archana. Our second expert is Dr. Naren Gupta. He is consultant gynecologist and IVF specialist at Vivekanand Hospital and Fertility Center, Jaipur. Past secretary, Jaipur FOGSI Society, editor Infertility Update newsletter. Chairperson ISAR Rajasthan Chapter 2324. And he has a lot of experience and received and has published so many papers. I welcome Dr. Naren Gupta, a very dear friend. And on this note, I welcome our panelists, Seema Prakash, Senior Consultant, Department of OBGYN, University College of Medical Sciences and GTB Hospital. Welcome, Dr. Seema. Dr. Kanchan Murarka, Senior Gynecologist and IVF Specialist, attached to Institute of Human Reproduction and Vice Chairperson of NESAR. Welcome, Dr. Kanchan. Dr. Jayarani Kamraj. She is Associate Secretary, World Association for Sexual Health, immediate past President FOGSI Society of Southern India, Vice President TAPISAR, Joint Secretary TNFOG. Welcome, Dr. Jaya. And Dr. Pratibha Makhija, young consultant in assisted reproduction, gynec laparoscopic surgeon from Bilaspur. I welcome you.
Thank you.
Dr. Sugandha Goyal is from Director of Kamala Nagar Hospital and in Rotary Club Jodhpur. Welcome, Dr. Sugandha. Dr. Priyanka Dilip Kumar. She is Consultant Reproductive Medicine, Milan Fertility and Birthing Hospital, Kumara Park, Bangalore. Welcome, Priyanka.
Thank you.
Without any further ado, can I share my slides? Yes. Can you see my slides?
Yes.
Yeah.
You will need to go full screen, please.
Yeah, I'm going to. So today we are going to talk about discuss about unexplained infertility.
Seema, you have half an hour for the panel since we were delayed. Apologies for cutting your time short. Okay.
Dr. Prateek, what are you saying?
30 minutes.
I said you have half an hour for the panel. Please go ahead.
So, yeah. So as we all understand, when doctor finds no cause for the infertility and failure of treatment, we label it as unexplained infertility. Through this panel, today we are going to really delve into whether it is really unexplained or we are making it unexplained. So what is unexplained infertility?
So, unexplained infertility is diagnosed when the standard evaluation in an infertile couple shows normal ovulation, a patent fallopian tubes, normal uterine cavity, and the normal semen parameters. Yet the pregnancy is not happening when the couple are going through an unprotected intercourse for 1 year. That is what the standard diagnosis where it says as an unexplained infertility. But unexplained infertility is not meaning that there is no cause. It means some conventional, some standard tests have not identified it. That is what we would like to say. It's not a dead end. It is always a diagnosis can still, with a proper, still more investigation, we can find out the diagnosis, the cause, and treat her so that she can get a pregnancy possibility. But the diagnostic focus nowadays looks into more of for the ovarian reserve, like AMH, AFC should also be included in this unexplained infertility. That's what the recommendation, many of the suggestions are given. But still, we have to look into the standard one of the uterine, tubal, ovulation, and the semen parameters. If they are normal, then we call them as an unexplained infertile couple.
Great, Dr. Jaya, you have almost covered everything. So whenever basically first line investigations like tubal factor, ovulation and semen analysis and tubal patency are at place and still patient is not getting pregnant, we call it unexplained infertility. And as you rightly said, it's not really unexplained. There are multiple factors we are overlooking and those things make it explained later on. So, my next question is, how many of you perform diagnostic hysteroscopy and laparoscopy before labeling a couple as having unexplained infertility? Dr. Kanchan.
Ma'am, for diagnosis of unexplained infertility, diagnostic hysteroscopy and laparoscopy is actually not done. So as Jaya ma'am told all the parameters, and here I would like to add one more parameter which is given in the latest unexplained ASHRAE guidelines, that the patient should have a coital frequency should also be normal. So if the coital frequency is also normal, including all the other parameters, then we'll after 1 year of unprotected intercourse, then we label the patient as an unexplained infertility. And just for the diagnosis, I would not like to go ahead with a hysteroscopy or a laparoscopy.
So
I want to add one.
Please go ahead.
Actually, we do HSG first, and if in HSG it is not clearly diagnostic, or just a minute, or if on HSG, if there is some confusion that we are not able to make a diagnosis on the basis of HSG, or there is it appears to be a fimbrial block or one-sided block, then we go for diagnostic hysterolaparoscopy.
So I just want to add up one thing. In ASHRAE guidelines, they say for the tubal evaluation, you can do a HSG or a SSG, but ASRM says that you must be sticking on only to the HSG. Laparoscopy and hysteroscopy are not recommended in the evaluation or in the diagnostic criteria for an unexplained infertility. That's what the guideline says. So there is no need for us to go for a laparoscopy or hysteroscopy for this diagnostic criteria for an unexplained.
If you have a doubt, then things are different. If any of the basic tests, in the basic test, if you have a doubt, then we go ahead. Otherwise, actually, it is not recommended. And if on the test, if everything is clear, if in the HSG the tubes are patent and all, then we don't need to do it.
So it is something like you have to correlate all the factors, including history, as we also stated in previous evidence-based literature that whenever the laparoscope is put inside a patient who's already been labeled as unexplained infertility, and around 40% of people, they are either suffering from mild stage 1 and 2 endometriosis, small polyp, adhesions, incorrect tubo-ovarian relationship. And that's in context to make explain there comes the role of laparoscopy, and it is not routinely recommended, as all of us agreed are on the same page. So we'll move forward. And Sunita, can you take this case, please?
Yeah, thank you, Dr. Seema. So wonderful discussion going on, and I hope everybody is enjoying. So this is case one, 30 years female, 32 years male partner with normozoospermia, regular ovulatory cycles on ultrasound, patent tubes on HSG, a good 3D ultrasound, antral follicle count 7 to 8 each side, trying for 1 year, unprotected intercourse, and patient is fully aware of fertile period, trying according to that, and the referring doctor has already excluded tuberculosis, has already done. This is how most of the time we clinically, getting patients in our OPD, that EB is already done. There is no evidence of tuberculosis. So this patient, obviously we can say that is qualifying as a case of unexplained infertility. Dr. Seema, can you please move on the slide to the next one? So how do we go about this? Or in other words, this patient who is trying for 1 year, should we leave her alone? They are young couple. Or should we move on to IUI? Or should we move on to diagnostic laparoscopy and hysteroscopy? So what comes first in your clinical practice? I would request all the panelists to say just single word about it, whether IUI is the next move or leave her alone, give her 6-7 months more, or diagnostic hysteroscopy and laparoscopy. Can we start with Dr. Pratibha, please?
Madam, first I will go through the whole history. If she has done any treatment with the previous doctor, so what time the ovulation was occurring, and if they have underwent ovulation induction, what time the triggering was given,
No,
whether it
ovulation
has ruptured.
induction is not done. They were
Okay.
just trying naturally. Now they have come to you. Tubes are patent. It's a normozoospermia case. And yes, ovulation was documented on ultrasound. It's unprotected intercourse happening. Patient knows the fertile period. Then
So
what is your
first thing,
next step?
yeah, the first thing I would like to know from the history, how they have been in contact, like what is the frequency of them being together. So if the frequency is fine enough, we can go for postcoital test, though we don't do it routinely nowadays. And if they show us a good PCT test, then the couple can try for another 6 months. If it doesn't come out to be positive, then we need to move further for IUI and other things. Yeah, like I would like to go for ovulation induction in the next cycle.
Dr. Pratibha, she is already ovulating. So ovulation induction is a word reserved for the people who are
Yeah,
not
yeah, ma'am, yeah. But in such cases, sometimes we do super ovulation,
super
like
ovulation.
super
Yes.
ovulation, so that if there are more than two follicles, there are better chances of conception in these women.
Dr. Sugandha, what is your opinion?
Since the duration of infertility and the age of patient is 30 and the duration is also less, so definitely I would go for IUI, and a patient can be given an option for laparoscopy and hysteroscopy, but it will not be the immediate step. If IUI fails, or if I'm suspecting any endometriosis or any other pathology, then definitely I will go for laparoscopy. But if since in this case HSG is absolutely
IUI is
normal.
your first option.
Yes,
All
IUI.
right. Then Dr. Priyanka, what is your
I
opinion?
think there's the woman is 30 and the man is 32, so no.
You are muted, Dr. Priyanka.
Sorry. Yeah. She's 30 and he's 32. She's ovulating, so I don't think I would offer expectant management any further. Since she's already ovulating, then the role of ovulation induction here is less, and I think an IUI is what I would opt for. IUI
So
with
ovulation
ovarian stimulation
induction plus IUI, right?
plus IUI. If
All
that
right.
fails, maybe go investigate further with a laparoscopy.
So I think most of us will agree on this, that we move on to IUI in this particular case.
Ma'am,
Fair
I
enough.
would,
Dr. Seema, can we? Yeah, you differ?
ma'am, here I would like
Now,
to
I
know
just,
the lifestyle, the BMI of the patient also,
yes.
because these days most of the time we get patients, who are on smoking
So her
or
BMI
alcohol.
is
The BMI is
26.
more.
She is a
Yeah.
BMI 26 patient.
So, first, though, I would like to see the lifestyle of the patient, advice on weight loss, lifestyle counseling, and stress factor and everything, the sleep pattern, whether they are doing exercises and all. First, I would like to change the lifestyle and see, because it's a very young couple and only 1 year they have been trying. So this is what I do in my practice, and most of the time the patients, they
All right.
conceive
So,
in
Dr.
3 to 4
Kanchan, tell
Yeah.
months.
me, when
So
we
I
leave
agree. I agree.
this
I
couple,
agree with Kanchan. I agree with
okay,
Kanchan.
ma'am.
That's very
So,
important.
if
Yeah.
we leave this couple alone, like they keep on having normal intercourse in their fertile period, then what do you think? What percentage of couple usually conceive in next 1 or 2 years with such a history?
13, some 10 to 15% of the couple may conceive within 1 year of an
6 to
expectant
8%.
management. So
Yeah.
But
sometimes
ma'am, I
within
will
three
not
years,
give a 1 year period. I will not give a 1 year period. Usually, I am telling the patients, you just to come again after 3 months, but a period of 6 months is what I give. Maximum 6 months period I give with lifestyle. And if after 6 months also they are not conceiving, then I go ahead with IUI or something.
Then you go
So
ahead with
I keep the
IUI.
patient
Fine.
on follow up. I just don't leave them for a year.
Can I come
Agree.
in here,
Agree.
Dr. Sunita?
Yes, ma'am.
I just want to put a comment here that the couple has approached you after an interval of trying, and these days couples have a very they come with a time frame that yes, we would like to conceive in this much time, and we would like our
Exactly.
investigation, because they are going from one place to another place, and that's like kind of a vicious circle. You again push them for 6 months that okay, try, and management, just try on your own, but they've been doing it in the past. So I think we really have to do something for them. We cannot be
Ma'am,
just
when we are trying,
advising them,
uh,
So I think what we can conclude here is, because they are trying in fertile period, and as Dr. Archana ma'am said that they have approached you with this problem that they are not conceiving. If we are not able to find any reason, sometimes the way they are doing intercourse is not perfect.
Yeah,
These kind of
that's
things
what
they
I
creep
was
in.
also saying.
Yes,
Yeah.
then the things are different, but otherwise counseling at 30, 32 years should be at least towards IUI, right? So
Yes.
I think that should be the conclusion and the message to the audience. Now, when we say unexplained infertility and we start actually investigating them further, and when we start diving deep into it, so do you really feel or believe that most of the cases they still are unexplained, or you feel that most of the times, we find one reason or the other? Or in other words, Dr. Seema, can you please enumerate, like, when we start investigating these couples, then what all things usually creep in?
So,
Yeah.
yes, Mita, the first thing is that whenever this couple comes to me, any couple who has been trying for more than a year or a year so, I try to take one natural cycle, because that is their angle. They have been trying and everything. And as you have rightly put, if we do not intervene here, they'll change the doctor and they'll just go window shopping. So there are multiple factors as I was talking, and in this natural cycle, the time of ovulation, kind of subtle ovarian dysfunction, endometrial receptivity problem, which we cannot diagnose on its own. But yeah, if everything is rest of the things are going fine and she's not conceiving, that could also be a reason. And the most avoided male partner where we are done with doing only semen analysis, not looking at his profile. Like we keep telling our female counterpart to lose weight and do things, and this guy who is sitting constantly on computers or doing sedentary jobs, and his lifestyle is on the toss, and sperm which is just showing the count and motility, there could be some problem. And as I previously mentioned, mild endometriosis or adhesions, chronic infection, chronic endometritis we have been listening to, symptomatic, asymptomatic, and not to mention genetic chromosomal anomalies. If we look into all these factors, then this unexplained infertility really becomes explained. So, sorry. So, in your practice, how many of you are doing, like in this particular couple who has been trying for a year, how many of you would like to go for a sperm DNA fragmentation test or any lifestyle modification you will look into and advise to the male partner as well?
But we look at the occupation first, what occupation he's into it and his lifestyle, like whether he's smoking any alcoholism and whether he's working near heat exposure, chemical exposure. Then we suggest DNA fragmentation in these men. And sometime in mild oats also, we suggest DNA fragmentation in these men.
And
If the
if the
sperm
normal
parameters
semen
are
analysis,
Definitely
then
the morphology and the sperm motility are the two criteria which we look into the women parameters. If there are two parameters are very low, then we suggest to look into the DNA fragmentation depending on the lifestyle, their weight, obesity, BMI, everything we will look into it.
so how many of us are doing in normozoospermia DFI? Is anybody doing?
No, we are
No.
not
No,
doing.
If there
not
is
doing it in normozoospermia.
Yes, here to
if there is
add.
lifestyle is not good, then I go
Yes,
ahead.
and that
Otherwise,
also we ask the husband to take antioxidants and coenzyme Q, etc. for 3 months, and
ma'am,
then
age, obesity, BMI, lifestyle, everything you see, age also, and if the
yeah.
patient is diabetic, hypertensive, those cases also, I'll go ahead. Otherwise, no.
Okay, we would like to take an expert opinion from our second expert, Dr. Narendra. What is your opinion? Do you do sperm DNA fragmentation for your unexplained infertility cases in male partner?
Like you said, that it is not required in every case. But of course, if varicocele is there, if the husband is suffering from varicocele, he is a smoker, chronic alcoholic, sperm parameters are abnormal, then of course we do sperm DNA fragmentation test. But in not in normozoospermic patients, and not at this stage, that is 1 year of infertility with normozoospermia. I don't think there is any role for DNA fragmentation at this stage. We won't do it routinely. Yeah.
Sunita, what is your opinion? Let's
Yeah,
conclude.
I feel absolutely the same. Normozoospermia cases, there is no need to do DNA fragmentation index routinely.
As a
But yes,
routine.
as a routine. But any of these histories which you have just enumerated on this slide, or suboptimal semen parameter as per WHO 2021, then we should look into it, especially if it is an unexplained infertility. We should do that.
So coming to the management criteria, so this patient, how will you proceed? Like many of you said that 3 to 6 months you will be giving for expectant management. And suppose that patient has not conceived. After that, also couple did not conceive. So what next?
IUI with ovulation
IUI
induction and IUI would be
will
a good option to proceed now.
So super ovulation with
ovulation with
IUI.
IUI.
Yes,
How
ma'am.
many cycles? How to start with?
We can start with the oral ovulogens because she's not a PCO. She would respond well either with letrozole or clomiphene. And then if she does 3 to 4 cycles is what I would do in my practice, not 6. And then if there is no result, either move to
Can I interrupt you for
diagnostic
a moment,
histola.
please? So the backend team, Dr. Seema Prakash is putting the message that she is not able to unmute herself.
Ma'am is logged in with 2
No.
devices, ma'am.
No, it is now I am able to unmute. Thank you.
So not more than 4 in my practice.
Okay.
So ideally speaking, according to the guidelines, ESHRE and ASRF guidelines, we have to give 3 to 4 cycles of IUI with the ovulation induction with the oral ovulogens, either a clomiphene or a letrozole. And both the guidelines are against gonadotrophins because of the fear of multiple pregnancies and pregnancy, cost and other complications, maternal complications. They are not for it. So by the guidelines, we can do 3 to 4 with the ovulation induction with the oral ovulogens. That's what the recommendation says.
So,
that's the recommendation, but usually,
those
but ma'am,
recommendations.
No,
here I
since it's
would
an
like to
ICOG.
differ.
No. ICOG, since it is the ICOG class, I'm telling the guidelines. But in our clinical practice, we do
We are
with the
using
proper
gonadotrophins.
ovulation induction should be ideally 2 or 3 follicles with a good size and a proper endometrium with the proper ovulation IUI protocols we have to follow. That is the one which can give you a better pregnancy. And of course, we all know that with the oral ovulogens, with the gonadotrophins, low dose gonadotrophins are the ideal ovulation induction that which we should follow for an IUI to have a better success, but
Dr.
by guidelines.
Yeah, Dr. Seema, what is your opinion? Like, our patients are self-supported. They are not being covered by insurance. Our institute is not providing free treatment for them. So, what is your opinion? Like, first cycle you did an IUI with oral ovulation, and patient did not conceive, and they are insisting they'll go for second IUI. So, second IUI, do you change anything or do the same?
Yeah, if ovulation induction has been successful with a low dose only, then we first give clomiphene citrate. If that is not effective, second cycle we try for letrozole also. And if that is also not effective in the second cycle, we don't get proper ovulation, then we try for injectable. Otherwise, we go for oral ovulation induction agents only.
Dr. Priyanka, Dr. Kanchan, and Dr. Pratibha, anything different?
Madam,
No, we'll
if
start
she
with
has
oral
responded
ovulation.
CC with 50 CC, if she has responded very well and has ruptured very well, then I will continue again CC. Otherwise, a single dose of gonotrophins on the day 3 gives a good result. So I have been following this and it gives good results. Yeah, because it will save further time also, further cost also. Because if you want to give further gonotrophin injections, that has to be given daily, and those will be costly, and it has to be given continuously. So single dose on day 3 will give good results, and it is to reduce the cost factor.
So, what is
Ma'am,
the
oral.
Ma'am,
rationale behind
usually
giving
what I am
on
doing
single
is
day?
Yes, ma'am.
Yes, Pratibha.
Yes, what actually, even though the recommendations say or that oral ovulations work, but in practically we all are, I think, giving gonadotrophins in low dose. So I am also starting from the first cycle only. I will start letrozole on 2.5, and I'll add gonadotrophins from day 6, 7, 8, and call the patient on day 9 and do a scan, because I aim here is always two follicles. So,
Yes.
so that the patient conceive, because she's a case of unexplained infertility. She's already has been ovulating. She already is getting one follicle, still not conceiving. So, two follicles is always my aim. So
Even
for
in
that,
my
I will
practice, ma'am,
so
super ovulation is key here. So oral ovulations with minimal dose of HMG,
minimal dose
one
of
or two doses
gonadotrophins.
of
Yeah.
75.
But you give in
Yes,
first
yes.
cycle only.
I will start in the first
Yes.
cycle only, ma'am.
I
Because
think as
In
far
uh,
as far
if
as
we
the
don't have,
guidelines are concerned, then oral ovulsions is the first choice drug unless
first
the
choice drug.
patient's age is on higher side. So let's stick to that. But yeah, in practices, many people are using sequential regimes also. But what Dr. Pratibha is mentioning, a single dose on day 3, I don't think either sequential you properly use, or you use a
yes,
gonadotropin till when you get at least the dominant follicle. And I mean, single dose on day 3, I will not agree on this.
Exactly.
yes,
No,
This
madam,
exactly.
should
it
be,
works
this
because you
should,
want to
no,
just
no,
surpass the
work,
No,
FSH
that is
threshold.
personal experience,
working
I
is
think.
Yeah,
different.
yeah.
It wasn't Dr. Pratibha, I think, who was giving this, Dr. Priyanka, I think, was telling, na, day 3?
No,
No,
Dr.
ma'am, not
Pratibha.
day
Dr.
3.
Dr.
I'll start
Pratibha,
with
okay.
Dr. Pratibha was
So
saying
it
that,
should
but
be, oh, sorry, it should be backed up by the endocrinology. What are we talking about? Either we are going to raise the threshold or we are going to increase the window.
Yes.
Day 3 single injection doesn't come in either of these two. So
yeah,
we should always talk like scientifically. So one single dose day 3 does not work either, as Dr. Sunita said. You go either with oral ovulation, your first cycle is failing, or monofollicular growth, you can switch over to sequential oral ovulation along with gonadotropin.
yeah,
That's
But
the
madam, in practical experience, if you see, we have to cross that FSH window. We are prolonging the FSH window. We are crossing one FSH threshold also. So what it gives a better. Well, but it is the experience is more than 10 to 12 years, and I have seen one senior consultant. We have been following them, so it gives result. Like if you want to give sequential regimen, those sequential regimen has never been approved because either you have to use CC or letrozole. But in Indian scenario, we are combining HMG or recommend FSH. We can combine at the minimum dose, like 50 units you can give. Book say you should write 75 even, but 50 also gives dose. 50 also give results. So if you want to give 50 recommend FSH for 6 days, that will also give good
See,
results.
Dr. Pratibha, if we go by recommendations, we have to first go with clomiphene, then switch over to letrozole. and
No.
then go to.
Can I speak now? How many of you are using clomiphene for unexplained infertility IUI, and how many of you have switched over to letrozole? And the reason.
Letrozole. Letrozole.
Letrozole.
Are using
More
Letrozole.
letrozole than
Letrozole.
clomiphene, ma'am.
Though letrozole gives
Did
monofollicular growth,
Monofollicular development.
still we are going with letrozole if we are,
Letrozole.
because the requirement of HMG goes down as it is an aromatase inhibitor. It pulls down androgen and that makes this follicle FSH sensitivity. First thing. Second thing, question to your answer of the FSH threshold and window. A person who has not achieved recruitment with your letrozole or clomiphene dose starting from day 2 for 5 days, there you can add one injection of
Yes.
HMG on day 2 or 3, but later on you will have to follow the same sequential or something, or you will have to go to total gonadotropin cycle. Experts, please correct if I am wrong.
I think one injection is not sufficient on day 2 or 3. I think 2 to 3 injections daily, at least 3 to 4 days. Matlab one injection daily, at least 3 to 4 days, 150 unit. That would give a good FSH.
I would
I think
suggest on the
I
base
think we
of
are
BMI.
deviating
We're
from
going
the
to add
topic. We are not
gonadotropin.
Yeah, no,
discussing
I would,
specifically the
madam.
doses.
Yeah, I know,
So
madam. I would suggest that 75 dose is the minimum dose we
Yeah.
start, and depending on the BMI, we have to give.
Yes,
Straight away,
that is also
150
important.
is not recommended at all.
Yes, we start with 75, and if
Yeah.
that is not responsive, then we go
We have
To
3 minutes left.
Okay, to the audience benefit, we would just like to conclude that you have to start the IY with oral ovulagens. Giving only oral ovulation for superovulation in cases of unexplained infertility does not bring better results. So it is always better to add it with IUI, that is ASRM 2020, and practically also we have been seeing, and that is what we are doing. So, Sunita, can you take this question?
yeah, so this particular couple who has been trying, and as some people feel that we can tell the couple to keep on trying for 6 months. So anybody who I just want, because we are short of time, somebody who can tell me how exactly, if they want to know about the ovulation kits, how exactly the kit should be used, the LH kit which are available over the counter. Anybody can answer this question.
Ma'am, I am using this LH kits since if I advise lifestyle and I give them a trial period of 3 to 4 in a good couple, good profile patient. So LH kit, I'll tell them to start depending on the cycle length, if, 28 to 30 day cycle length, if the patient is having, then from the 9th or 10th day at evening 3 to 4 p.m. time, that time I'll tell them to put 2 drops of urine. The day they get to line means they're about to ovulate within next 36 hours. So next to next day, I'll tell them to stay together. Like after that, or next 2 days, I'll tell them to stay
Right.
together.
So I would quickly would like to read these slides. Dr. Seema, can you go back? Because most of the people, my audiences would like to know. So how frequently you are supposed to tell to you, as Dr. Kanchan said. So these are more convenient, less invasive. Women may be instructed to record their fertility window over few menstrual cycle. It's starting from day 10, 11 of menstrual cycle, you can tell them depending upon the cycle length. Highly sensitive kits can detect LH as low as 22. Mean time interval after a positive LH kit test to the rupture is around 20 plus minus 3 hours. So this is important, like once you start seeing 2 lines, but most of the time, it may not be reliable also. So that you have to remember. But, we keep on telling our patient use ovulation kits, but how to use them rightly is also important. So LH surge sometimes may not signify true ovulation. That is important. And sometimes the LH surges are extremely variable. That's why they become little less reliable. Sometimes there is a rapid onset and within 1 day, sometimes there is gradual onset of LH surge. So that is why, and also this premature LH surge, it doesn't trigger ovulation in around 46% of the women. So can we move on to the next slide? Best time, as Dr. Kanchan said, is between 11 to 3 in afternoon.
Can I ask one thing? What about the app? People come with that. I'm just following it on app. So how many of you really tell them, like, okay,
Ma'am,
Ma'am, the app basically,
whatever this app and LH kids, it's really have a very bad effect on their sexual life, ma'am. To be very honest, because
That's
exactly.
very
the
true.
time the
Yeah,
intercourse,
technical.
it becomes we are peeping into their bedroom, and many of them they come with a very sad point. We never did a sexual intercourse at that time because it is the problem with their mind, and that goes into a lot of
Psychology.
stress in the couple. Ideally speaking,
Dr.
this
Seema,
I
I
will
think we
not recommend. I will
So
not recommend for this.
rapid fire. First line treatment for unexplained infertility between 35 to 39 years of age. One
IUI.
line
OI,
is please.
OI
IVF.
with IUI.
I will
how
go
many
with
OI with
cycles?
IVF.
IUI.
How many cycles of IUI?
4.
Three
Three
cycles.
Three,
cycles.
three,
We
three
Between
cycles.
like the
35 to
number
39
3.
also?
Between
35
cycles?
3 cycles.
Three
Not
cycles.
if the
I will
woman
go
is
for 2 cycles between 35 to 39. I wouldn't want
me
to
too, me
waste
too,
time.
me
The
Yeah.
too.
duration of infertility will also be a matter of
It's
concern.
matter, yes.
Yeah,
Duration and reserve also.
Okay,
yes,
Then we have to
exactly.
wind up now.
No.
more
Yeah,
than
so
40, just give 2 minutes, Pratik, please. 2 minutes, more than 40 years first line treatment.
IVF.
IVF.
What
IVF.
about luteal phase support?
Yes.
Yes.
There is a
According to
role.
the guidelines, there is no role.
No
No,
role.
I don't.
I'm talking about the practical
We
experience.
are
I'm
giving
saying
the
Yes,
practical
Practical
luteal phase
experience.
support
experience.
to
it
each and
has
Okay.
to
every
be.
patient who is
Yes.
undergoing IUI. What about you
Yes.
guys?
We give.
Yeah, we give.
In
We
If
have
IUI,
it's
we
a
It
will
is
give.
simulated
given.
cycle, yes, we give.
It has to
Yeah.
be given.
Simulated
It
cycle
has
we
to
will
be
give.
given an
Otherwise,
IUI
no.
cycle.
Yeah.
And this patient, when should all of these, starting from 30 to 40, are you agreeing that after certain number of IUI cycle, patient should be referred to ART?
Yes.
Yes.
Yes,
Yes.
exactly.
Yes.
So
No,
lifestyle
but
mod.
then there is a asterisk here that, if the couple is really young couple and you've tried 3 cycles of IUI, you may take that patient for now laparoscopy and
Yes,
Yes.
hysteroscopy.
me
And
too.
if everything is absolutely fine, I think you give her 1 or 2 more cycles. But yes, if age is on higher side, you find endometriosis there, you find some infection there, you find some additional cause there, then yes, definitely. Even in PCO girls, most of the time, if 2, 3 cycles are not working, sometimes, we are not able to make them ovulate only with hardest of our efforts. So there we need to move on. Dr. Seema, can we quickly go to the concluding slides and read just 3, 4 concluding
No,
slides?
my sharing was stopped, so I cannot
Your
do
That's
any
panel
okay.
is
more.
Dr. Pratik,
unfortunately over.
This is
can we just
cheating.
say the
30
concluding
minutes is
slides
not good
from
for a
ASHRAE
panel.
guidelines?
Strict
Okay,
teacher.
go ahead.
Strict teacher, Pratik. Strict
One or
teacher.
two fine concluding slides, and we have to do the posters because people are waiting for the posters.
So
Right.
what do
So
okay. You open your presentation and just speak because now sharing is not an option.
Q&A option. You can go ahead.
Okay.
You can read from
Somebody's
your
disabled
slides
your
also.
sharing.
You can read from your phone also.
This was the most important and interesting part. Yes. Sunita,
So
please.
even so, Dr. Sonia Malik has already covered this
Microbiota.
microbiota. So definition, all of us are clear. Infertility in couples, apparently normal ovarian function, fallopian tubes, uterus, cervix, age less than equal to 40 years. This is also there in ASHRAE 2023. So when it comes to 40 years, we don't more than 40 years, then we can't call this as an unexplained. Normal testicular function, normal ejaculate, and at least 12 months of trying. Ultrasound, preferably 3D is recommended. Laparoscopy as a first line, not recommended. Postcoital test, not recommended. Routine vaginal microbiota test is not recommended. Then IUI with ovulation
From
induction is the first line of treatment. Then even when you are trying an expectant or active treatment, IUI with oral ovulogenics is the first line. IVF is not the first line treatment because we've already said that definition says less than 40 years. And it is expected that the decision to use IVF is individualized by patient characteristics such as age, duration of infertility, previous treatment, and all. And ICSI per se is not recommended in unexplained infertility. Hysteroscopy not recommended as first line. HSG is recommended. Endometrial scratch not recommended. And once you find mild endometriosis or minimal endometriosis on laparoscopy, this is no more a case of unexplained infertility. Oral antioxidants not recommended either in male or females. Acupuncture not recommended. But yes, psychological support, a healthy diet, regular exercise, and lifestyle modification is definitely recommended. So
So
thank you
thank you
all.
very much to
And
our excellent moderators, experts, panelists. 900 people are waiting for the post-test link at मेरे नाम से
Thank you.
सुपारी
Thank
निकलेगी
you.
if I don't share the link now.
Thank you,
thank you
Pratik.
so much for
Thank
having
you.
Thank you,
us.
sir.
This was
Thank you,
for,
sir, and
thank you,
thank
Thank you,
Pratik.
madam.
But this was also for those 900 people. We wanted to convey the correct message so that when they
Thank
go
you.
back
Thank you
home,
very much
they
for
have
all the
actually
hard
learned
work
it.
and the effort that you
I
took
think
in putting together this panel.
we can talk, but let us start the link. So
Yes.
in
Correct.
between we can talk. Okay. So
Yes,
we
Divya,
need
can you
all
please
of
share
you
the link in the
because
chat
people
box
will
and
start
on the
at least.
screen?
yes.
So,
Thank you, dear panelists. You all were awesome, full of knowledge.
Thank you,
Thank
moderators.
you,
Thank you, ma'am.
experts,
Thank you, madam.
Thank you, ma'am.
Dr.
Thank you.
Narendra and
And
Dr. Archana, ma'am.
Dr.
experts,
Pratik.
yes, Dr. Narendra and Dr. Archana.
So the
Link has
link
been
for the
posted in the chat box, sir.
yeah.
link is in the chat box and you can post the QR code also on the screen. Please do not raise your hands because nobody is allowed to speak here. You can post your messages in the chat box if necessary and if you think that they are relevant and pertinent. In case you are being disturbed by us speaking, you can reduce your volume.
Good suggestion. I think link is repeatedly been pasted there. You can start.
These students are more concerned about post link, no?
Certificate is important, Seema. Not
Yes.
everybody is a VIP and an expert like you.
अब मैं ही बची हूँ.
Many of our audience require to provide those certificates for their career path continuation, etc. It's important for them. That's why you see a lot of the messages in the chat box, even while the speakers were speaking in previous program का अभी तक attendance certificate नहीं मिला.
Last year का भी पूछ रहे.
और अभी भी during panel the same questions link.
There are people who have attended for 1 day, for half an hour, and for 3 days they want the certificate.
Anyway, all of you appear for the test. I know that you were very attentive. And don't forget Bangalore conference 21st, 22nd and 23rd of August. Fertility and beyond. Seema आना है.
Yes, ma'am. पक्का. कब है?
Delegates
अभी
also.
तो बोला 21st, 22nd, 23rd. You're not paying attention.
अरे मैं पढ़ रही थी चैट बॉक्स की, कोई आंसर करना है क्या क्वेश्चन? किसी ने
Not
लिखा
able
है
to open link.
कपल को
Somebody is
वेकेशन
telling
पे
you can
भेज दो.
scan the QR code. And thank you all moderators and panelists, Sunita, Seema, Kanchan.
Thank you to all of our chairpersons and our
Jairani.
excellent speakers who did more than justice to the
Thank you, ma'am.
task. All of the presentations were unique, they were original, they were not recycled, as I keep saying, and all the speakers
Exactly.
had
Yes.
researched their
Yes.
presentations very well. They had worked very hard on them.
Latest up to dates.
Correct.
Very good. Very good.
Jaya, thank you.
Yeah, thank you. You're welcome, Seema.
Yes.
Congratulations to the conveners for today.
Thank you, Pratik.
Monday,
Thank
end
you.
of the
Thank you, Pratik.
journey. I think we are off to a fantastic start. We had more than 1,150 registrations and live audience of more than 950 at one point.
Yes.
Right till the end.
Yes.
So one final task is left, and that is conveying the correct answers after 11 minutes and 35 seconds. The backend team will share the answers, and I would request the coordinators for today to share the correct answers to the audience. And in case you're busy, I will do the meeting.
No, me and Jaya will do. Jaya will start.
Okay, great.
Mani, you post your question in chat box. We would like to answer if question is related to the topics we are talking about.
Ipsita has submitted successfully. She's the first time. Thank you, Ipsita. I don't think you need this certificate.
I too did it, Pratik.
I too did it.
I did it before that. I did it before that.
You should have posted in the chat box.
Yeah, I didn't see that. Then she posted, then I put it.
I submitted too, sir.
Thank you. Thank you. All are appreciating. Very good. Thank you.
So for the benefit of those who have come late, we will have to wait out the complete 10 minutes.
So, Mansi is asking how endometrioma is related to recurrent pregnancy loss.
Do you want me to answer it?
Yes, please do.
Okay, so endometrioma and endometriosis are related to poor oocyte quality. They are also going to be related to poor fertilization rates, poor implantation rates. And these patients are also known to have aneuploidy because of various reasons, the least of which is, of course, endometriosis and advanced maternal age. Many of the patients who have endometriosis also have advanced maternal age and poor oocyte quality owing to that reason as well, all of which creates a perfect storm, and then ultimately you are going to land up with pregnancy loss. Some of them may be early pregnancy losses, what we used to call in inverted commas blighted ovum in the past, where you will see a pregnancy implantation.
So
Your
yeah,
visa
again,
will be
repost the
positive.
test link again. Somebody is asking for the link quickly.
Yeah, some people come late and then they miss that message. So these are some of the reasons why endometrioma and endometriosis can lead to poor pregnancy rates as well as early pregnancy.
So I was reading that fecundity rate for a normal female couple newly married within first year is around 15 to 18%, and that for an endometriosis female becomes 5 to 6%. And the reason being endometrioma, I'll just add, because that endometrioma, as Dr. Pratik has explained everything, this endometrioma is full of hemosiderin. So this is a pro-inflammatory kind of status. Along with that, it does some immunomodulatory effects, and that is leading to pregnancy losses, though there are different views like IVF pregnancies. They say once patient becomes pregnant, the chances of continuing that pregnancy is equivalent to any other female. But we have been seeing that the rate of success is lower, and that is those are the reasons which have been given by Dr. Pratik.
So I think we'll wait for another 7.5 minutes because there are still some people who may not have submitted. There are some people who log in only at around 7 o'clock because they want to do only the post test. And keeping to time is important because many of them have evening OPDs and they schedule their work accordingly. That's why I had to cut it short. Apologies.
I think you can review the recording on ICOG website. I think we are going to have 2 more days, and all those things, whatever doubts you people have, will be covered.
Sita, all certificates will be sent to you by email.
Pardon?
If Sita is saying congratulations, but certificate bhi chahiye, so I said certificate email se aa jayega.
Somebody joined at 3:55.
There are still people who are asking that there is pre-test. In 2026, we have done away with pre-test. This is the 4th certificate course that we are doing. So for those of you who have not done the previous certificate courses and are new to this entire concept, we don't have pre-test anymore. We only do a post-test on each of the 3 days. Anybody who gets 50% on each of the 3 days totally will receive the certificate as per the rules and regulations. Those who don't get the 50%, will receive only a certificate of attendance, but you need to have attended at least 2.5 hours on each of the 3 days.
Dr. Renu, your question is very generalized. Each and every fibroid does not cause infertility or miscarriage until unless it is submucosal fibroid that can lead to infertility or pregnancy loss. But rest of the fibroids, it is very generalized question. What exactly do you want to know?
So I see some of our GCMs are still logged in. Thank you, Dr. Richa, for coming in. I saw Dr. Shashibala a little while earlier, and Dr. Uma Pandey was also there. Dr. Tarini Taneja had logged in. Thank you all our GCMs for being there as part and parcel of this
आपका
program.
question क्या था?
Thank you.
Oh my God. We'll have to go back. There are people asking, answer our question. Anita, what is your question? I'm still trying to find it.
Ask her to copy paste the question.
Please copy
It's
paste the
easier, na?
question. It's easier. Yeah, I am
Doc-
going
Dr.
backwards.
Nagratna is also logged in. Sheila Mane madam. And she submitted the test.
Nice to see. I know many people today. Anita is there. Anita is also there.
Preliminary LH kit
Richa,
should be
Anita.
used routine in IUI cycle or USG Doppler monitoring is enough for deciding. If you have USG and you can do it, nothing like it, why are you going to go for these LH kits are for people who are not coming frequently to visit you. If you are doing follicular
Charu.
monitoring, additional LH kit monitoring is not required at all.
Shashibala.
Those are not very reliable, as you heard. That is, there are situations where you cannot call. Is there weekly positive? What? Or
On LH kit,
for 2
weekly
lakhs?
positive.
Yeah. LH kit. So I am not a big proponent and very fond of LH kit. So
I wish you had focused on ultrasound
Shantala.
monitoring
yeah,
rather than this LH kit, because unnecessarily people will keep
Hi,
asking you.
Anuradha.
दिल रखना पड़ता है
Akshita.
सबका. I prefer to do DHL before opting for IOI in unexplained infertility.
Pratibha is there. Hi,
So for the
Pratibha.
first day, we have intentionally kept simple questions. Dr. Ritu Khanna is logged in. She's muted. I think she's
Dr.
logged in as
Shilpa,
else.
DHL is fine, but anything when we are giving evidence-based answer for the masses, things which are less invasive, less expensive come first. Since IUI is less invasive, less expensive, there is no anesthetic complication, intraoperative complication. So we prefer going for IUI first before deciding to go for laparoscopy. And that too, we decide on the basis of her symptoms, her ultrasound findings, and rest of the things.
So Dr. Ritu Khanna is here. She's our
Hello,
coordinator for
sir.
day
Good evening,
3.
madam. The
Hi,
whole
Thank
session
you for
was very
coming in.
nice. I was there since the beginning. It was very nice today.
I know.
Thank you for
Yes.
joining us. Look forward to
Yeah.
seeing you in Varanasi soon.
In a case of
Yes,
endometriosis,
waiting.
not ovarian endometrioma, planning for egg freezing, should surgery be done first before USA? If you are planning to do egg
Pratik,
freezing,
are you
then
going
why
to
will
do
you
answer
surgery
discussion?
first?
Yeah, Seema and Dr. Jairani are taking care of it. If they are busy, then I will do it.
So is it done?
नहीं,
So
वो अभी 2.5 minutes हैं.
okay, freezing should come first and then you decide for good surgery. And that should be done in expert hands. Not everyone can deal with deep-seated endometriosis stage 3 and 4, especially with rectal nodule, ureteric involvement. So whenever you are planning for endometriosis surgery, oocyte freezing as per ASHRAE guideline also, you should be giving the option either for oocyte or embryo freezing. So before surgery, you should do the retrieval.
Is 10 minutes over, Shreya?
Not yet, 2 minutes to go. There's a timer at the top.
And
Dr. Shashibala has also done the
Shashibala,
posting.
Pratibha, Anita, Richa.
Rajeshwari, unruptured
Pratik.
follicle even with 10K SCG. 10K SCG, first of all, is 10K, no, 10,000 international units. Okay. SCG is not required for majority of women weighing starting from 40 kg to 90 kgs. and 5,000 is enough if it has been given at correct time, at correct size. So you have to follow. If it is a CC cycle, the trigger should be given on 22 plus. If it is letrozole cycle, 20 plus. If it is gonadotropin, 18 plus. And if you have the color option, color flow option in your ultrasound, you just put the color. If your follicle is having more than 3-4 circle of color, that means this follicle is ready. So first of all, you have to check the timing, and then you have to check the batch of your SCG. If both are fine, next cycle try to do natural or change the ovulation, change the trigger.
Look at your cold chain maintenance. Sometimes the recombinant
Yes.
will achieve results.
Mention, yeah. And you can give recombinant also, yeah. Dr. Anurag sir.
I think Sadhna Gupta is also there. Welcome, Dr. Sadhna.
Hi, Sadhna ma'am.
Hello, madam. Good evening. Thank you for coming.
A patient
So our
has.
time is up. Seema, time is up.
Okay.
Shreya, you can stop sharing.
There's question in my chat box.
So Shreya will share the answers.
Jaya is going to.
Questions and answers.
Dr. Jairani and Dr. Seema can go through it. Yeah. Welcome, Dr. Sadhana Gupta, ma'am. Thank you for joining in. Good to see you. I have sent you an unmute request.
Hi, Anita Di. Hi.
Hello. Great panel.
Hi, Dr.
We
Pam.
enjoyed.
So time is up, and now we have the discussion of the answers.
So the answer for this MCQs of day 1 of our ICOG certificate course on infertility. The first
Only
question,
answers.
the
You can
commonest.
read only answers. Okay.
Okay,
Yeah.
the first question is the commonest cause of anovulation is PCOS. FDA recommends maximum dose of clomiphene citrate per day is 150 milligram. Adverse effects of letrozole if the daily dose goes above 7.5 is thin endometrium. Time required to complete a cycle of step-up protocol is 28 days. Estimation of which two hormones are essential for the cause of anovulation is FSH and prolactin. Tubal factor infertility is best diagnosed initially by HSG. The gold standard for diagnosis of pelvic endometriosis is laparoscopy with histopathology. A patient with bilateral hydrosalpinx planned for IVF should ideally undergo salpingectomy or clipping before IVF. The hysteroscopic finding, which is mostly associated with infertility, is an endometrial polyp. AMH primarily reflects the ovarian reserve. The first line of ovulation induction drugs in PCOS, according to the current evidence, is letrozole. Chronic endometritis is commonly diagnosed by presence of plasma cells. Poseidon criteria classifications related to classifications of poor ovarian responders. Unexplained infertility, a standard infertility evaluation being normal. Which of the following is not a part of baseline hormonal evaluation is serum creatinine. Best time for measuring the basal FSH is day 2 or 3. Which condition is strongly associated with thin endometrium and infertility? Asherman's. The women with infertility and recurrent RPL should be evaluated for uterine cavity abnormalities. The most appropriate management of minimal mild endometriosis and infertility may include surgical ablation or excision with a fertility treatment follow-up. A 32-year-old woman with infertility has regular cycles, normal semen, analysis of partner, and bilateral patent tubes. The next appropriate diagnosis is unexplained infertility.
So thank you very much to the conveners. And the questions for today's MCQs are very simple and extremely basic. A 5-year-old would have got them right. So I expect at least 700-800 people to have got the answers right, more than 50% of them. In fact, I would expect a lot of 100% as well there. So at the end, I'd like to express my gratitude to the ICOG office bearers, Dr. Sheila Mane, Dr. Ashok Kumar, Dr. Sarita Bhalera, who is my co-convener, and Dr. Sadhana Gupta. Thank you for this opportunity. I would also like to place on record my gratitude to Dr. Seema Pandey and Dr. Jairani Kamraj, who are the coordinators for today, the first day, female factor infertility and fertility enhancing surgery. We had 1, 2, 3, 4, 5, 6 excellent talks, which were done by stalwarts of OBGYN and infertility in India. My gratitude also to all the chairpersons who showed up. Fantastic panel at the end, which unfortunately I had to cut short because 900 people were waiting for the post-test Thanksgiving flu murder. Unexplained infertility was dissected excellently as per the guidelines, and also a lot of key practice points and messages regarding practical treatment of unexplained infertility as we do it on the ground in India. My gratitude to our experts and panelists for such a lively discussion. Thank you to the backend team led by Dilima, Poonam, and Shreya for doing the honors and for taking care of the post-test as well for us. We had more than 950 delegates who were logged in simultaneously at one point of time. And I hope to see all of you in the audience tomorrow as well for day 2 proceedings. When we talk about male factor infertility and IUI, a lot of your queries on IUI, which are there in the chat box, I didn't personally respond to because that is going to be discussed extensively tomorrow. So until tomorrow, goodbye, God bless, and see
Thank you. Thank you all. Bye. I think, can you just share the
Thank you,
conference
madam. Thank
brochure?
you.
Backend team conference brochure. Thank you, Jairani. It was excellent.
Thank you, ma'am.
Thank you, everybody.
Thank you. Thank you.